is about to begin. We ask for the participant on site to have a nice seat. And we would like to kindly ask all participants, panelists, moderator, to switch the mobile phone to silent mode to avoid any interruption during today's agenda. Good morning, ladies and gentlemen, participants, proctors, moderators, and panelists. Assalamualaikum warahmatullahi wabarakatuh. Shalom. Welcome to the first International Cardiovascular Summit Harapan Kita. Ladies and gentlemen, International Cardiovascular Summit Harapan Kita is our first conference and will be held annually to show our masterful achievement in cardiovascular procedure at National Cardiovascular Center Harapan Kita. Organized directly from our proud operating theater and catheterization laboratory to demonstrate interventional procedures such as LA occluder, leadless pacemaker, endovascular intervention, structure and congenital intervention, valvular intervention, and other. On the occasion of the 58th National Cardiovascular Center Harapan Kita anniversary, the International Cardiovascular Center Harapan Kita is as part of sharing new technology for our proud network hospital across the nation by presenting 5 countries, Japan, Hong Kong, China, South Korea, and Indonesia. This summit is held as a stepping stone in the biggest conference in health industry now and in next future. Ladies and gentlemen, for the next 6.5 hours, we will learn and discuss through live demo on endovascular repair, minimally invasive surgery, leadless pacemaker, and zero fluoroscopy. Let me read to you.
Okay. Good morning, everyone. Welcome to the second day of the International Cardiovascular Summit in Harapan Kita. Thank you for joining us in the very early morning in the weekends. So we will have several sessions today. The first one being the endovascular interventions for aortic diseases. So with us, we have distinguished panelists, Dr. Isman, from my left side, Dr. Isman Firdaus, Dr. Suci Indriani, Dr. Rini Pramesti, and Dr. Emmanuel Upangat. We will have a lecture from my mentor, Professor Sung Kwon Kang from South Korea, who is a professor in Chosun University, South Korea, as well as the CEO of SNG Biotech, who produces many aortic devices. Then we will have a live demonstrations from our cath lab, a complex aortic case in which Dr. Iwan, our President Director, and Dr. Taufan will perform the interventions, and you are welcome to join, to observe, and of course to give us your valuable insight about how we best approach these patients with endovascular interventions. So first of all, I would like to call my mentor, Professor Sung Kwon Kang from Chosun University and SNG Biotech. The title would be Endovascular Treatment for Complex Aortic Pathology. Although Dr. Kang has been around for more than 10 years in Indonesia, he will deliver this, the lecture not in Bahasa, but in English, not Korean, right, Professor Kang? Go ahead, Dr. Kang.
Okay, thank you very much.
Recording in progress.
Thank you very much for your kind introduction, Dr. Suko, and all panelists. I would like to express my sincere congratulations to Harapan Kita Hospital to establish the International Cardiovascular Summit, and congratulate for 38th.
Yes.
39 is next year. Okay. The life is going in the lab, and I'm going to talk about the endovascular treatment for complex aortic pathology. Actually, complex aortic pathology means normally the complex aortic anatomy. So today, I would like to talk about all the new device. I'm working with Jantung Harapan Kita Vascular team for the complex aortic anatomy. Next, please. Endovascular aortic repair offers several advantages, as you may know, when we compare the surgery and the endovascular treatment, where all the clinical evidence has been established already. So the first EVAR has been done in 1990s, and in 5 years, the number of EVAR go over the number of the surgery. So these days, for aortic disease, endovascular treatment can be chosen as a first-line option. Next, please. Then, when I define the complex aortic disease, the aortic disease with complex anatomy. So the aortic disease means thoracic aortic aneurysm, and aortic dissection is representing diseases. Thank you very much. All the aortic pathology with the anatomical suitability. Actually, when we compare the surgery and the endovascular treatment, the only limitation is anatomical suitability. As you see here, there is a big abdominal aortic aneurysm, but if there is a significant angulation, it can be the complex aortic disease. And if there is aortic rupture or underlying disease, it is much more complex because we cannot treat the patient with a standard method. We need the more sophisticated complex device or the procedures. Next, please. The management of the complex aortic disease can be multidisciplinary approach. Actually, these days, the endovascular treatment of the aorta can be done by mainly cardiologists or vascular surgeons, cardiothoracic surgeons, radiologists, and the other specialties. But as you may know, these days, many hospitals, they establish the hybrid room, and they can make a good collaboration between department and specialties. So the thing for the complex aortic pathology, the diagnosis and planning is very, very important. So diagnosis and planning need to be done very carefully, especially for the complex aortic disease. Next, please. We're thinking about aortic pathology with the new devices, the aorta from aortic valve and the aortic arch and descending thoracic aorta. And as you see here in the slide, actually the region of the interest is aortic arch and thoracoabdominal area because there are many branches. So in the beginning era of the endovascular treatment, it is very difficult to do the endovascular treatment in this area, in aortic arch and thoracoabdominal. But these days, many innovative devices are coming for this area, aortic arch and thoracoabdominal aorta. So we can use branch or fenestration, single or double branch or fenestrated device for aortic arch, and multiple fenestration or multiple branch, such as the T branches from Cook are coming for the thoracoabdominal disease. And we can do the standard EVA for abdominal aortic aneurysm, but even though abdominal aortic aneurysm, it could be challenging when the neck is very angulated and small or the large. And when the abdominal aortic aneurysm include the common iliac artery, it can be complex aortic pathology. Next, please. So first of all, we're going to go to the aortic arch lesion. The aortic pathology involves the aortic arch branch vessels, such as left subclavian artery and left carotid artery. It can be treated by standard endovascular treatment. Next, please. When there is arch pathology, well, in the endovascular treatment, there are many limitations because there are many branches, supraortic trunk vessels, innominate left carotid artery and left subclavian artery. And also, when we do the endovascular procedure, we need to preserve the valvular function and coronary flow. And when we do the endovascular procedures, there should be some complications. Actually, we still have the reliable number of the cerebral ischemia due to embolization and occlusion. And the device migration can be happen because the aortic flow is very fast around here, and then arch is curved, and then the flow, the turbulent flow can be happen. And when we place many devices, the device disconnection can be happen, and also in aortic dissection, when we do TVAR, the significant complication can be happen, such as retrograde dissection. That means the stent cause new intimal injury, and then dissection extend into the ascending aortic aorta. So that means type B aortic dissection converted to the type A dissection. Next, please. So before endovascular procedure and new innovative devices are coming, we have used the hybrid procedure. Actually, as you see here, if there is a pathology, aortic pathology in zone 3, there is no problem to do the endovascular procedure. Just we can do the standard TIVA procedure. But if the lesion involves left subclavian artery or the left carotid artery in zone 2 and zone 1, that probably could be the problem. So these days, single fenestration or single branch or double fenestration or double branch device are coming. As you see here in the slide, the hybrid procedure, we can do the surgical bypass from left subclavian artery, between left subclavian artery and left carotid artery over here. So as you see here, we can save the vertebral artery here and then make a bypass with a conduit between left subclavian artery and left carotid artery. And sometimes in upper photo, we can do the bypass from right innominate artery to left carotid artery and left subclavian artery. It's like the debranching of the two vessels. Then we can do the zone 1 TVAR. Next, please. So fenestrated and branched devices are coming these days. Very active research and development is done. Then as you see here, the single branch device from Gore and single branch device from Medtronic. So we can use these devices for zone 2 TVAR. As you see in the figure, if there is zone 2 landing between left carotid artery and left subclavian artery, we can land the proximal part of the stent graft in zone 2 and then make a hole for the left subclavian artery and place branch stent graft in left subclavian artery. The advantage of this single branch device, so when we place the branch stent graft, the stent graft stability is very nice. So it doesn't migrate, and then we can do secure sealing at the proximal landing zone. Next, please. So I'm going to show you this new device, new innovative device, working with Dr. Suko. He is a moderator today. The two-wire system and modified olive tip to facilitate the implantation of fenestrated TVAR in patients with proximal descending aortic pathology. Actually, we can do the zone 2 TVAR very securely with the device. So when we see the advantages of the device, we can achieve the safe and secure zone 2 landing, and then we can treat distal aortic arch pathology. And this is very easy technique, so high technical success rate and feasible technical steps. Next, please. So this is the figure of the procedure. When you see the device, there is 2 holes in front and 2 holes in the back. So the device have single hole, 1 cm distance from the margin of the fabric. So when we place this device, we can use 2 wires. So as you see here in the slide, figure A shows, first of all, we can advance the guide wire from the femoral artery and the wire captured from left brachial artery. And then we capture out the wire from left brachial artery. That's the single first wire. And second wire from the femoral artery, same puncture, from the same puncture, the wire goes to the ascending aorta. So, well, another wire can go to the ascending aorta for diagnostic catheter. And then we can advance the stent graft delivery system over these 2 wires until the olive is located at the left subclavian artery orifice. And then we can open until the hole is exposed, and then we can push up the delivery system until the hole is aligned to the left subclavian artery orifice. Next, please. So I'm going to show you the technical steps, step by step. The first of all, as I mentioned before, previous slide, the two wires in place. One is from femoral artery to the left brachial artery, and second one is femoral artery to the ascending aorta. Next, please. So we can place the angiographic catheter from left brachial artery. So you can see the marker catheter from left brachial artery to the ascending aorta. So we can perform angiography during the procedure without any difficulty during the procedure. So, well, in ascending, there are two wires in each vessels. In left brachial artery, two wires. In ascending aorta, two wires. And descending aorta, and two wires. Next, please. So we perform angiography from left brachial artery, the angiographic catheter from left brachial artery. So as you see here, big aneurysm. But the location, where is the location? It's zone 3. This is theoretically zone 3, but do you think we can do the zone 3 TVAR? Well, there is a long proximal landing zone in the greater curvature side, but lesion is very close to the left subclavian artery in the lesser curvature side. So, well, I can say there is no safe landing zone in zone 3. So we make a decision for the zone 2 TVAR with a two-wire system, single fenestration. So one thing, this slide is very, very important slide. There is an arch anatomy here, as you see. The arch is bovine type, but the important thing is zone 2 landing area, the distance between left carotid artery and left subclavian artery. So you can see maybe 1 cm landing between left carotid artery and left subclavian artery. Then only in this case, we can do the zone 2 TVAR with a single fenestration. So all devices are all the same. The Gore device, Medtronic device, any device, they have at least 1 cm distance from the hole to the margin of the fabric. So at least we need 1 cm distance between left carotid artery and left subclavian artery. So anyway, the angiography shows the lesion location in zone 3, but there is no safe landing zone in zone 3. Next slide. Next, please. So this is the later phase of the angiography. You can see the vertebral artery. So the vertebral artery far distance from the left subclavian artery origin. So we need to confirm the location of the left vertebral artery because we need to place the branch stent graft below the vertebral artery origin. Next, please. Now we are advancing the stent delivery system over 2 guide wires. So as you see in the previous slide, there is 2 holes in the front, in the olive. So 2 wires goes in the 2 holes, and then we can advance the delivery system over 2 guide wires until the olive is located at the left subclavian artery origin. Next, please. Next, please. Here you can see the olive is located at the left subclavian artery origin. Then from here, we can deploy the stent graft by pulling. Actually, normally, standard deployment technique is pulling back. So hold the pusher catheter and then pulling back the sheath. But in this device, in this procedure, we need to push up. So we need to hold the sheath handle very firmly and then push up the pusher handle. So the hole goes up, need to goes up to the left subclavian artery orifice. Next, please. So as you see here, the hole, you can see the hole. There's a hole marker. I'm not sure you can see, there is a marker at the outer sheath, round marker, and near the round marker, there is a hole marker, radiopaque hole marker. So the hole marker needs to be aligned to the left subclavian artery origin. Can I use the pointer here?
Yes.
Really? So they can see the audience. They can see this marker, this pointer. They can see
only in the
audience.
room. Only in the room.
Only for the room, right? Yeah. Anyway, this is the marker. This is the marker, hole marker, and this is the outer sheath marker. So we deploy the stent graft by pushing up. This is going up by pushing. So this marker goes to the left subclavian artery origin. So next, please. Okay, so the hole marker is approaching to the left subclavian artery. So at this time, the proximal part of the stent graft is captured, not open. So the proximal part of the stent graft is captured until the stent graft is fully deployed. Next, please. Yeah, the stent graft is almost deployed, but at this slide, you need to see the hole marker is aligned to the left subclavian artery. So the wire curve is very natural. So there is no kink. It makes natural curve. That means the hole is well aligned to the left subclavian artery. But the proximal part of the stent graft is still captured. And next, please. Okay. We open the proximal part as well. And at this time, the angiographic catheter is located in the ascending aorta, but it is located outside of the stent graft. And the hole is aligned. The guide wire securely pass through the hole to the left subclavian artery. That means all position, we can manage all position in the right purpose. Next, please. Okay, and when we perform the angiography during the procedure, the aneurysm is gone already. So we can exclude the aneurysm completely at this time without placing the branch stent graft. But as you see here, the hole is 70% offset. So completely 100% is aligned, is not aligned. But there's no problem. We have a chance to make it right, make the alignment well by placing the branch stent graft and balloon inflation. Next, please. Okay. Now we are deploying the branch stent graft over the wire from femoral artery to the left brachial artery. So as you see here, there is a marker here. This is the branch stent graft marker from here to here. So this part is flared. And after the branch stent graft deployment, we're going to perform the balloon dilation. Next, please. Next, please. Okay. And after branch stent graft deployment, we extend distally with a one more stent graft to secure distal landing zone, to make the secure distal landing zone. Next, please. And when you see the final angiography, there is a junction kink. There is a junction, at the junction, there is a wasting in the branch stent graft, as you see here. Over here, there's a narrowing of the junction. So we need to place the balloon dilation, need to do the balloon dilation for this. Next, please. So we perform the balloon dilation again for the junction. Actually, when we perform the single fenestration or the single branch or double branch or single fenestration or double fenestration, even for the in-situ fenestration, the junction is very, very important. So the junction needs to be secure, and the junction leak can be happen. So we need to manage the junction very carefully. So we perform the balloon dilation. And next, please. As you see here, the junction is much better right now. And then we can finish this procedure successfully. So we can exclude the aortic pathology, and all target vessels are patent. That's the purpose of the fenestration or branch vessel, branched stent graft. So exclusion of the aortic pathology and all target vessel patency. Next, please. This is another device, but similar technique, called FASG. The safety and efficacy of novel fenestrated aortic arch stent graft with a preloaded catheter for supraaortic arch vessels. So this is also single fenestration. The device is almost same, but the technical steps is a little bit different. So as you see here, there is the single hole from the 1 cm from the fabric margin. Next, please. This is the configuration of the stent graft, a single hole and double hole. Okay. So this is a little bit different because there is only one hole in the front, but there's two halves in the back. As you see here in the picture over here, in the front, there is only one hole. And there is another hole inside of the delivery system. So pass through the fenestration. Next, please. Okay, this is the animal study. And next, please. When we actually try to success of the procedure, where we do one fenestration in 6 and 2 fenestration in 5. So all technical success has been achieved. Next, please. This is the histological figure. The CT scan shows single fenestration, single branch, and double branch, and single fenestration and double fenestration. Next, please. Next. Okay, angiography shows the saccular aneurysm in distal arch. Next, please. So we need to check the marker in vitro before the procedure. Next, please. Next. Yeah, so where I'm rotating the delivery system to align the whole, this hole and hole marker and bank marker. This is the hole marker and bank marker, 2 markers here. Next, please. And then I'm advancing the delivery system and open until the hole is exposed. Next, please. Through the hole, I advance the guide wire and select a branch vessel. Next, please. And finally, I deploy the stent graft totally and open up the proximal. And next, please. Yeah, I'm advancing the branch stent graft. And final angiography shows, next, please. Very good alignment, and the lesion is completely excluded. Next, please. Okay, what about the lesion in the proximal arch? In this case, the saccular aneurysm is located in the proximal arch. So we can not use single or double branch. So we used the 2 branch stent graft. Next, please. Yeah, as you see here, very complex procedure. Through the carotid arteriotomy, first device placed in the ascending aorta, and second device from left carotid artery to the descending aorta. And finally, 2 branch stent graft can be connected by 1 stent graft. Next, please. Then we can go to the descending thoracic aorta. In the descending thoracic aorta, the limitation can be the collapsed true lumen in dissection patient and tortuous aorta. Next, please. Wow, when I see this kind of tortuous aorta, wow, this is crazy. So I would like to run away from the patient. This is very difficult to do the endovascular procedure, but if we do use through and through technique from femoral artery to the brachial artery, we can place the stent graft successfully. Next, please. Then thoracoabdominal aorta. Actually, there are many abdominal branches. Okay, you can go. Next, please. As you see here, there are many branches, and the limitation is proximal and distal landing zone is quite far away. And branch vessels, wow, there are many branch vessels. Or intercostal artery, Adam-Kiewicz, renal artery, celiac artery, there are many. So there are risk of paraplasia and mesenteric ischemia. So this area is the most challenging area. Next, please. So when we want to do the FT-VAR or the branch T-VAR, we need to make a sophisticated planning. So measure the location and size and distance. Next, please. Yeah, here, the location. So we usually use the clockwise measurement. And then we need to make the 3 demodeling, and then 3D printing, and then we need to see the location and size directly. Next, please. So when we measure in 10 patients, the celiac artery size is about 6 millimeter, SMA 8 millimeter, right renal artery 5 millimeter, left renal artery 5 millimeter, and distance are all here. Next, please. But excuse me, if there is a lesion in the thoracoabdominal, well, sometimes we can do the procedure simply. This is the patient with a post-operative complication. The neurosurgeon did the disc surgery, but they punctured the aorta. So next, please. As you see here, there is a iatrogenic pseudoaneurysm in here, but the location is in the back. So we can make this kind of device, HAP5 stent graft. Next, please. So there is a lesion here, large circular pseudoaneurysm, but even though there are many branches, we can place the stent graft, saving anterior wall. Only the stent graft is located in the back. So we can exclude the lesion successfully, but save all the mesenteric branches. Next, please. Until now, the fenestration and branches in thoracoabdominal is evolving. So this is the report from Dr. Shenja, 2017, with 100 patients. The 50% is commercial, that's custom made, and 50% of the device is physician modified. The result is quite fair. Next, please. Now we can go to the abdominal aorta, where if there is a neck angulation, hostile neck, short neck, access problem, contralateral limb selection, where there are many complex hurdles. Next, please. The limitations, if aneurysm neck angulated, there should be the complex aortic pathology, the infrarenal, the internal iliac artery preservation, and the access need to be big. Next, please. This is the report about the kilt for neck angulation. Next, please. We are using this thoracic device for kilt and very significant neck angulation, and then we placed this device first, and then using this device as a landing zone, we can do EVAR. Next, please. The clinical outcome is quite good. Actually, the kilt, after the kilt, next, please. Next, please. As you see here in this graph, the neck angulation is gradually straightening. So the kilt has a very nice technical success and clinical success. Next, please. Sometimes contralateral limb selection. Next, please. When we do EVAR, most doctors, they are worried about the contralateral limb selection. While sometimes we cannot go in the contralateral the limb. Otherwise, it takes 1 hour, 2 hours. But sometimes in 1 minute we can select. But it's very unexpectable. But this device, Dr. Tofan developed, and then we are working on this. Actually, there is a skirt in the distal. So even when we place the ipsilateral limb here, then there is a big skirt. So it is very easy to select contralateral limb. So as you see here, I'm deploying the ipsilateral limb. So until here, all the procedure is straightforward and simple.
Tes 1, 2, 3, 3, 2, 1. Huh?
Minute for Dr. Kang to finish. Sorry.
Oh ya sudah, saya sudah
Okay,
ngomong
ready.
tadi.
Yeah, go ahead, Dr. Kang.
Yes, thank you. Actually, where I would like to show you this, the contralateral limb selection. As you see here, there's a big skirt, so it is very easy to select contralateral limb. So it takes in 1 minute or 2 minutes. So just 1 or 2 try, we can select contralateral limb. Right? You can see here the contralateral limb selection. Okay, next please. Okay, the last one is the iliac branch device. Next please. Actually, we need to save internal iliac artery at least one side. So to preserve internal iliac artery, we can use this kind of device. Next please.
Belum. Udah.
Next please. This is the case. Next. 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 Yeah, this is my last slide. My take-home message is endovascular treatment is getting used more and more, and complex aortic disease, even for the complex aortic disease. Thank you very much.
Thank you very much, Dr. Kang. I'm very sorry for the trouble in the cath lab. So I previously asked him to go slowly, and after the problem in the cath lab is resolved, I asked him to speed up the lecture. I'm very sorry, Dr. Kang.
No problem.
So you may sit here, Dr. Kang. We are ready
yeah.
for the live demonstrations. So Dr. Iwan and Dr. Taufan, are you ready from the cath lab? Can I have?
Is it clear? Is it clear?
Yes, we can hear you clearly, but we have not been able to see you.
Oh, really?
Yeah.
So I think that we can see clearly here. Okay, can we see the...
Now, I can
Okay.
see you now. I can see you now.
Okay.
Yeah.
Okay, very good morning, ladies and gentlemen. Dr. Sukok, can we start this program from the cath lab, right?
Yes. Please first tell us about the patients. I am seeing you with Dr. Taufan and Dr. Diki, right? So
yeah,
can someone tell us about the patients?
Right, okay. Very good morning, dear colleagues. Can I see the slide, please? Okay, this is the endovascular repair in complex aortic case. I'm the operator with the Dr. Taufan, and slide, please. Okay, we have Dr. Rendra Mahadika, fellow from Surabaya. The cardiothoracic surgeons in charge, Dr. Diki Algeri and Dr. Cardiac Yoga for anesthesiologists. We have Dwi as a radiographer and scrap nurse, Uup, Dodo, and Sofatul. We have anesthesia nurse on board, Uni. So I think this is a very interesting case. Can I have a next slide, please? Okay, I think Dr. Taufan will talk about these very interesting cases. Dr. Taufan.
Yes, thank you, Dr. Iwan Dakota. Thank you for the audience.
Just
and
a minute.
also,
Yeah, I wanted to full screen, yes. Continue, Dr. Taufan.
okay, thank you, Dr. Suko. Thank you, Dr. Iwan Dakota, for your introduction. Thank you for my team, and also for Dr. Suchi, Dr. Noel, and also Dr. Rini. And the other one is maybe for my mentor, Professor Kang. I have one case talking about the aortic dissection, actually type B aortic dissection. The patient, he already done TFAR, the previous one, 7 months ago, but came to the hospital with chief complaint, recurrent back pain. And we going to do the CT evaluation. The patient got the type 1E embolic, and also with the symptom. The patient, the endolymph of this patient is very big. The diameter is nearly 7 cm. And also the patient got the percutaneous angioplasty for the LED, and the other one is still good, but the RCA is not dominant. The patient, he also got the hypertension, and we plan to do the re-intervention for the covering the endolymph type 1A, Dr. Suko. And the patient also, he underwent left subclavian bypass to the left common carotid bypass, and the patient, he have about the complication about the brachioplexopathy and also ischemic CVD. That is my case, Dr. Suko.
All right. Can you show us the CT scan prior to the intervention?
Okay. So this is the CT scan, Dr. Suko. We can we proceed the playing for the CT scan? We can see clearly T4 done already, but that's very interesting because the leaking type 1, the maximum diameter is about 7 cms. But interestingly, that the stent is not well expanded because of very steep angulation. I think that is one of the big challenges. Slide.
So
Slide,
basically, this patient underwent T4 and had type 1 endoleak, right?
Leaking, right,
So,
right.
yeah, okay.
The type 1 endoleaks after seven months, I think, right, T4.
Yeah,
So we can see clearly, we calculating the diameter of the proximal part for landing zone is 33.5, let's say 34. Then the length of the free view stent graft is 180 millimeters. So what is our planning? Next slide, please. Next slide. The common iliac, both common iliac is still okay. I think it's more than 8 cms, and there is no any stenosis at all. Slide. So actually we can use both right or left, but we choose the left groin cut down by the surgeons because the right one has already cut down 7 months ago. So what is our planning actually? Slide. So this is the most important thing that I would like to show you, that there are changes. The challenge, number one, how to deliver stent graft on steep angulations. You can see that one, because there is could be a big problems migrating the previous stent grafts, jumping forward, and a little bit stenotic, about 2 cms on here. Number two, the challenge is regarding to what is the proper size for our stent graft, because the 34, we choose the 36 or 38. And the last but not least, the precise positioning of stent graft to cover the type 1A leaking. So we have 3 axes, the left groin for the main stent graft, left brachial artery to as alternative for bailout, and then right brachial artery for control angio. Slide. Next slide, please. Okay, so actually what we are planning is regarding to cover the type 1 endoleak. Slide. Okay, this is. I suppose most of you have already known there is so many zones in the thoracic aorta. There are 5 zones, including zones 0, zones 1, zones 2, and zones 3. Mostly we did the zones 3, right? Now we are covering to left subclavians. We are going to the zone 2 TIVAR, actually, to put another stent graft to cover the left subclavians in order to exclude the type 1A leaking. Slide. Okay, I think that we can skip this one. Slide.
All right.
Next. There is another option for zone 2 TIVAR. What is the reason and our strategy? Slide. Next slide, please. Okay. We are going to the zone 2 TIVAR. Slide. Okay, this is another option if let's say we have the doing proximal extensions to cover the endoleak. So another option, if let's say we still have a leaking, we can put vascular plug or glue. If there's no endoleak, just leave it alone. We just proceed as a completed placing of the stent graft. Slide. Okay, this is another option. If let's say we fail and we cover the left carotid artery, we have a bailout alternative. We can put the balloon to left subclavian arteries in the way that we can, last but not least, if let's say we fail this one, we can puncture directly to the left carotid artery to put the stent or chimney. Slide. Okay, this is type 1 endoleaks that we can see. Our planning is to put a proximal a stent graft, which is positioning on proximal part of the previous stent graft. Slide. Okay, slide. This patient has a bypass. Okay, this is our aim. It could be cover the left subclavian or partially cover the left subclavians to exclude the type 1 endoleak. Slide. Yeah, if let's say we did this one successfully, we completed this kind of procedures, right? Okay, we have this site. Either we use, sorry, it's not 38 because we calculating 34. So meaning that we can use 36 in diameter of the stent graft with the length of 150. We have on board 18 French to 20 French sheath, pigtail catheters, and then we have another wires as well, right? This is that I have already. We have 3 punctures, 3 access, left groin, right brachial, left brachial. Slide. Okay, Dr. Suko, we would like to show you the initial angiogram showing the leaking type 1, even it is a sluggish flow actually, very, very small leaking from the proximal part of the stent graft. Can you see here?
Yes.
We take 3 or 4 angiogram, then the last angiogram showing a leaking, a small leaking from the proximal part.
Right, right. Can everybody see the endoleak just after the left subclavian artery? Right.
Okay, Dr. Suko.
Yes. So while you're
while
you're continuing the procedure, may I ask the panelists? We have
sure.
Yeah, we have Dr. Emmanuel here, Dr. Rini, Dr. Isman, Dr. Suci, and of course Professor Kang with our panels. Would somebody comments, Dr. Noel or Dr. Rini first? Any comment about the strategy of Dr. Iwan and team? Oh, Dr. Isman, please, Dr.
Yes,
Isman.
okay, thank you, Dr. Suko. For regarding the strategy for this patient, very tough and complex. How about the 22 French? I think it's, the big you cut down or just only puncture for this kind of patients? Maybe preparing for closure device. Dr. Iwan.
Yeah.
Yes, Dr. Isman, thank you very much. Actually, we use 36 by 150, meaning that we can use 18 French. But actually, we calculating either we use 18 or 22 French because the size of 38 or 40 in diameter needs 22 French. So that's why we need a cut down. We need a cut down for this kind of patients, and cut down already done by the Dr. Diki Algerian teams. So we use the cut downs on the left side, and then we puncture both left and brachial artery for a control angio as well as for bailout if let's say we have a difficulty or we have failed.
So right, because by definition the closure device can only accommodate up to 21 French, right? So although it has been used in several occasions, but officially the closure device can only accommodate to 21 French.
Right, right. So that's why previously we're thinking that we used 22, right? 22 friends. So that's why we need to cut down, not using this one. But we calculating this morning the size of the landing zone of the Arctic Arch is 34. So we use 36 in diameters, meaning that we can use 18 fans. But anyway, it has already cut down by the surgeon.
All right. Yeah, thanks to Dr.
Okay.
Diki, right? So any other comment from the panelists or from the audience? Dr. Kang or Dr. Suci?
Yeah, thank you, Dr. Iwan, Dr. Tovan. So in this case, why do you choose the left subclavian to left carotid bypass? If you, we see that we want to cover in the zone 1, so can we do the branching, and then so we can move a little bit forward and land in the zone 1.
Yes, Dr. Suci, that's a good question. Actually, once this patient coming to us, to Dr. Tovan previously, with the complaining of the back pain, and then we see clearly there is leaking from the CT scan. We plan to cover this one. But the most important thing at the time, we will fully cover the left subclavian artery. If let's say it's a big leaking, right? And then if the small leaking could be a partially, but in view of totally cover the left subclavian arteries, there is two options. Number one, to have a bypass from left carotid to subclavians, or leave it alone. We have several cases that we just cover this one, and we must sure that there is a good collateral from above, from the circle of Willis. So for this patient has already got the bypass from left carotid to the left subclavian. So meaning that we can do a type 2 zones, meaning that we can fully cover actually the left subclavian arteries. This is the worst scenario.
Yeah, because I saw that the zone 2 landing is very narrow, so maybe we'll cover the partial occlusion of the left carotid arteries.
Yeah. Yes, 1 cm, less than 1 cm. But our planning here, so I cannot see clearly the bypass. So we have already discussed that we will partially cover the left subclavian artery in order to only to exclude the type 1A leaking. So we are not fully cover this one because actually previously we are doing a perfect type zone, type 2 zones, meaning that we will cover the distal part of left carotid artery, but the risk is still there. So we will choose, we just cover the left subclavian artery.
Okay, thank you, Dr. Iwan.
Yeah. Another option is, of course, branch it or a chimney for both carotid or subclavian. But we try to use the simple one. Yeah. Just only put a stent graft, another stent graft to cover the left subclavian artery in order to close or to exclude the type 1A leakings. So
yeah, Dr. Iwan, are you proceeding with the deployment of the stent graft?
Yes.
Yes.
Can we see the? No. I will show you how we bring the stent graft. Can we see that? No. The previous, because previously we still think that we should be very tough to deliver stents, to bring stent up. Now, as you can see here, can you see Dr. Suko and all panelists? We put already this kind of seal stent graft, 36 by 180. The positioning is just after the left subclavian arteries, the markers. So we will deploy there in order to cover, fully cover or partially cover.
Would you explain the marker, Dr. Kang, for the benefit of the audience? There are several markers there. Can you explain which marker is for what? There are two markers there at the proximal part of the graph. the radio opaque marker.
Markers. Those two markers for the fabric margin. So the two markers align to the target vessel. You can align the two markers to the target vessel.
Yeah, so the marker serves as the origin where the cover stand
Yes.
started, right,
Yes,
Dr. Kang?
right.
Yeah, so right behind it is the cover stand. So we might place the
two marker ini.
yeah, the marker just below the carotid, left carotid artery, right?
So Dr. Kang, Dr. Suko, just make sure that the two marker is the bare stand, but the one big marker is the stand graph beginning, right?
Yes, yes.
Okay, this position, what do you think, Dr. Kang? Are you happy with this kind of position? Otherwise, I will bring it forward.
Yes, please go ahead.
Okay,
Yeah.
so we can do this one. Can we see it here? Can we show this one? No, zoom to this one. This is the system. So we can open this one, right?
So, yeah, Dr. Iwan, please proceed. But
Okay, maju dikit.
unfortunately, we cannot see the marker of
Maju dikit, Man.
the supraortic branches here.
So I can open this one now. I will deploy.
Yeah, please go ahead.
Sorry.
So you're deploying by rotating,
Yeah.
right?
Yeah, I can see this one. You can see that I try to open this one. Yes. So Tovan, can you see here? It's still on the right side, right? This is the distal of left carotid actually. We can bring it. How about that, Dr. Kang? Should I bring it back or
Just rotate,
here?
just rotate. Just rotate.
Just rotate, okay.
Yeah.
Right. So
Yeah,
we,
I know.
we also have pigtail marker from right brachial artery, right?
Right.
Dr. Iwan. So it
Yes.
it's also serve as the marker of the brachiocephalic trunk.
Yes,
So
you're right.
Yeah, so we need to place the marker distal to the pigtail marker. So we won't close the
Okay,
brachiocephalic trunk.
Aku tarik aja. Ya. Tapi enggak. Okay, I can open this one. Can you see that? I can bring it back.
Yes,
A bit?
yes.
Bukan, begini, sini sedikit. Whole system tarik sedikit. Okay. Here I think, right? Ya. Oke. Sampai habis ya. Sini kan, Pan? Okay, are you happy with that? So we still need. Oh,
Okay. So there's also a quick deploy. Dr. Iwan is
yes.
performing the quick
I
deploy
deploy already.
procedure.
Now capture.
And the
Now we can see the delay.
yeah.
The
yes,
delay.
Yes.
I will take the delay closer.
Rotate and pull out.
Yes. Record. I think that on that position, I think that's good.
It's not completely deployed.
Okay,
Dr.
now
Iwan,
we can
the
take it.
proximal part.
Yeah.
Maybe we need waiting for the completely deployment, Dr. Suko. So because the proximal part not yet completely
Open.
deployed.
Yeah. So what do you think, Dr. Kang? Should we be waiting? Usually it takes time for waiting. Olive tip?
Olive tipnya udah dikeluarin kan?
Belum?
No, no, no.
Not yet?
It's okay, it's okay.
We should waiting for opening the proximal part, right? Yeah, but we take out this one for balloon. So what do you think, Dr. Kang? What is your opinion about that? We should waiting for the opening of the proximal part.
I need to see the flow.
Yes. Dr. Kang is coming down, Dr. Iwan.
Okay.
So he needs to see the fluoro to see whether the delay deployment system of the proximal part of the graph is working. So the position seems to be correct.
Right, but the thing is the proximal part still not fully open.
The delay deployment system is not working, so what you gonna do?
Can we see the last fluoro of the Suko?
Yes, yes.
Okay.
Yes.
If it is open, the two markers separating, I think.
So while waiting, you have several operators and of course anesthesiologists there. So as operator, we used to concentrate on the procedures only, and sometimes we did not pay too much attention to the hemodynamic. So how do you maintain the hemodynamic during a TFAR procedure? Dr. Iwan, Dr. Tovan, and Dr. Diki?
Yeah. Actually, we keep the BP is not so high because there is a possibility that we will to post-dilate balloon after that. That's very dangerous if we using. We should keep the BP is relatively low during inflation of balloon.
Okay.
Because the BP will be went up. Will be go up is exceeding more than 180. But right now I think the BP is about 100. Previously we can keep it 100, I think. 100 over 60, 100 over 70.
So usually during deployment we lower the blood pressure. And sometimes in the critical position, sometimes the other operator use pacing to make it a standstill position.
Right. You're right. To keep the BP in control, right? Relatively low.
Right. So if if the panelists and audience have any comments whatsoever, please feel free to jump in.
This one is clearly.
Yeah, first, Dr. Ini, you may address the question to the operators.
Dr. Iwan, when we have to put like the second stent graft to protect to overcome the endoleak, can you just guide us how to measure? How we put the second stent graft to cover the endoleak, but the measure is not too big or too small, and also how long we need to protect safely for the endoleak, so we can.
Yeah, thank you very much, Dr. Ini. That is very important question, I think. Since we have already calculating the size of landing zones of the aortic arch, is about 33.5, let's say 34. We choose maybe either 36 or 38, but we decide to choose 36 in diameters. Why? Because if we use 38 or 40, there will be a problem, not a leaking, because of the stent will not well oppose. Looks like a crimping. So we should choose the proper size. The proper size that we calculating, if the diameter is 34, we prefer to use the 36 in diameters of the stent graft.
Oh, I see.
So, so that's the point.
Then about the longer of the stents, which was safe for to close safely for the endoleak.
Yeah. Yes, Dr. Rini? Is there any other question? Sorry.
Okay. The length of the ideal length of the stent graft, or we close the endoleak safely, doc.
Oh yes, this is the big problems. We should cover more proximal. We should put on the graft portions more proximal to the previous one. Of course, this is the most important thing. So previously they just landed at the distal part. This is zone 3. Yes. Now we are going to zone 2, meaning that we fully cover or partially cover the left subclavian. But just remember, zone 2 is very crucial here because very short zone 2 between left carotid to the left subclavian artery. So we prefer to fully cover the left subclavian or partially cover. This is beyond to the previous stent graft just after the left subclavian artery. I think the aim of our putting stent graft is to put little bit proximal to the previous stent graft in order to exclude the type 1 leaking.
Oh, I see. Thank you.
All right. All right. I think the teams is discussing the strategies they are going to take to overcome the undeployment of the proximal graft. So let me ask Dr. Suci. Yeah, of course. Any discussion from the audience and the panelists while we are waiting for the operator to solve the problem?
Dr. Suko, I'd like to ask something, maybe all the panelists and you as the moderator, one of the expert of vascular intervention. What actually symptom for this kind of patient, the indication for TIVA?
Right.
In general, in patient with aortic aneurysm or stenosis like this.
Right. So, any panelists, Dr. Noel, Dr. Rini, or Dr. Suci, please?
Maybe, thank you, Dr. Risman. If you see that there's actually branches of the aorta, and if there is aneurysm or if there's aneurysm or dissection that closes or obstruct the branches of the aorta, that makes the symptoms of the patients. It's actually, you could get a stroke, you could, if there's a closure on the carotid arteries, you can have like a pain in the abdomen if there's a closure of the arteries, the branches from the aorta, and the types of symptoms that can lead to the discovery of the aneurysm or the dissection of this type of disease. I think that's my question. That's my answer.
Any additional comment, Dr. Rini?
No.
Dr. Suci?
Yeah, so in general, we do the endovascular intervention is for the aortic problems, such as the aneurysm, for dissection, and also for stenosis. Some of our patients with the mid-aortic syndromes also we perform TIVAR in that case. I want to ask Dr. Suko about the hostile neck and AAA. When do we choose the kill technique, and what is it kill technique, and when we choose kill, can the kill technique overcome the hostile neck? Or we do the Ics-Hk or something like that for the hostile neck?
Yeah, of course there are several definitions of hostile neck, which includes very short neck or landing zone, very tortoise or angulated neck.
Is it open, right?
Reverse tapered neck or conical neck.
Okay.
And also calcified and the neck with a lot of thrombus. So kill technique is only aimed for angulated.
I don't think so. Right?
For angulated neck. So they put first the stent graft, long thoracic stent graft, and they continue with the main body.
I think because of like this, right?
So it's
So-
going to overcome the angulation.
The angulation.
Yes. Yes, Dr. Suko.
So, can you update us, Dr. Iwan?
Yes,
Looks
we
good.
did already review, and after pull out the olive tips, we can pull out the olive tips, then we take the final angio. Can you
Right.
see here the final angio? The stent graft was fully open. So it well in good positions. We cannot see the type 1A leaking.
Right. So the stent graft is located just after the left carotid artery.
Left carotid artery, right.
So my question is, we already have the bypass between left carotid to the left subclavian, but it seems that the origin of the left subclavian artery is not ligated. Would you continue
Yeah.
with coiling or plug at the left subclavian artery, Dr. Iwan?
No, actually we cannot see the endoleak anymore. So it is not 100% fully covered the left subclavians. There is still space actually. So that's why you can see the flow to the left subclavian artery. But the most important thing that we cannot see any type 1A leaking to the distal part of the aorta, especially to go to the false lumens. So I think, what do you think, Professor Kang? I think, are you happy with the results? Yeah. The most important thing, Dr. Suko, why we are waiting so long for fully deploy of the proximal part. So one of the explanations from the Professor Kang, because of the steep angulation, you can see this one, the very steep angulation of the proximal part of the stent. So once we deploy this one and complete it, we have already deployed the final deployment. The proximal part is still there. It takes some time to fully open. Then once we take out the olive tip, it has already fully opened, and we take the final angio like that.
Right. I think the endoleak has been occluded. My question is whether we need to close the origin of the left subclavian artery to prevent from type 2 endoleaks.
Yep. Mhm. Yes. Professor Kang, do you have any comment with that?
Actually, the segment is blind only, so we gotta perform the curve, change the curve.
Mhm.
Right now?
Later on? The most important thing that I cannot see clearly the bypass from the left carotid to left subclavian. So the thing is that I cannot see clearly. I'm not quite sure whether the bypass is still there. I mean, if we occluded the left subclavians, is there any problems with others? Because our aim for these procedures just to cover the type 1A leaking, right?
Maybe we can evaluate.
Can we evaluate after that? Yeah, Dr. Suko, you have a good question actually, but I think we just discussed about that. We can do either plug, vascular plug or whatever to close this one, but it is sometime can we evaluate this one within 1 week or 2 weeks later on?
All right. So any questions from panelists or audience? So is it, Dr. Iwan, is it necessary before we put a stent graft during aortogram to see the patency of the bypass? Maybe we can put the fluoroscopy a little bit higher to the cranial position, to the cranial position so we could evaluate the patency of the graft?
So we have
The bypass?
We have the angiogram. Can we show the angiogram which is showing the branches of the aorta? The previous, yang sebelumnya ada tuh. The previous angio, we can see higher. No? This one, Dr. Suko.
Right,
Can you see
right.
here?
Yes, yes.
But I cannot see clearly the bypass. Whether the bypass is still there or occurred, I'm not quite sure because there is no any CT scan review of this kind of bypass graft.
Yeah.
I cannot see the bypass, so that's why I
Okay.
just leave it alone for the time being because there is no leaking at all. Then we will review. If let's say there is a leaking later on, so maybe we still consider to put the vascular plug. Otherwise, if there is no leaking, just leave it alone.
Yeah.
Right.
I think that's the best option because we cannot see clearly the carotid to subclavian bypass. Then
So that's the point.
we will preserve the flow into the left subclavian artery, either from bypass or from antegrately from the aorta, because we have no endoleak whatsoever anymore.
Yeah, I think that for the next, since this patient have the 3 specialties, let's say they will do a cabbage in the next futures, there is still a pattern and then easy to have a lima to LED, let's say. We cannot sacrifice this one. There's still a pattern, I think the flow to the left side clavians. Okay, Dr. Suko and panelists, I think that's all that we can share with you all.
Right.
We have a lot of problems, but we can settle up this one. Hopefully that we can learn from our procedure this morning. Thank you very much anyway.
Thank you very much, Dr. Iwan, Dr. Tovan, Dr. Diki, Professor Kang, and Nurse Uk. Well done.
Thank you very much, and see you all. Thanks semua ya, yang ada di ruangan. Terima kasih. Boleh, lihat aja.
Yeah, we still have around 25 minutes actually. So the intervention went so well that we finished in 30 minutes before the schedule. So any raise of discussion, Dr. Noel?
Maybe just for the sake of discussion, if it's possible, before we finish the first procedure, just to foresee whether there will be endoleak or not, whether we just like a post-dilate the stent with a balloon, so the position of the stent really placed to the wall of the aorta. Is it possible, or is it how to say within the procedure that can be done through the prosthesis?
Yes, actually the graft is self-expandable, so it actually requires some time to fully expand. So when I see some endoleak, I usually first wait for 10 minutes. If the endoleak is quite small, I usually wait for 10 minutes and repeat the angiogram. If the endoleak is getting smaller, I would again wait for 10 minutes. And if there's a trend towards more and more, less and less, less and less endoleak from time to time, then I would leave it. But if there is a large endoleak in which I think the full expansions of the stent graft would not help, then I would balloon it first.
Okay.
Or using other strategy, using endo-anchor or proximal extensions of the graft with fenestrations. Or we can wait for another session. For example, in this patient, we need the bypass from carotid to subclavian or from carotid to carotid, then extend proximally.
Oh, okay, yeah.
Okay.
So Dr. Iwan, Dr. Tovan, and Professor Kang, and Dr. Diki, you are welcome to join us up here because we still have some discussion
30 minutes.
for 20 minutes now. Dr.
Okay, Dr.
Isman?
Suko, I will ask about these procedures. What actually happened when the tips of stent graft are not open? So what the strategy for the Dr. Iwan Dakota at that time to open the situations? Because I think it's scary, scary, delicious.
Yeah, yeah. Of course, that is why that is the actually why every surgeon, every interventional cardiologist should have a sufficient number of caseload, because having sufficient number of caseload would expose you to variations and complications. So.
For these procedures, what actually happened?
Yeah, we had what we call the delay deployment system to secure the proximal part to deploy the last. So we have the control at the tip of the handling system. So when we deploy, then the last to be open is the proximal part. But sometimes it's not working like this. It's not working, although we have pulled the trigger, the proximal part of the stent graft is not open. So there may be several strategies to do that. To overcome this problem, we can wire from the from the contralateral side, proximally, and balloon. Because we cannot pull down. Sometimes we cannot pull the olive tip because it may stuck in the proximal part of the graft and may even drag the stent graft distally. So, so I think they're doing a very good job to manage the complications.
Dr. Suko, sometimes we have the very, that's why we case a complex aortic problem, that the dissection has have multiple tear, even on the thoraco, also abdominal, so thoraco, abdominal, aortic aneurysm. How to overcome the patient with the complex dissection like this?
Right. Dr. Suci, you want to help me? multiple tear.
Involving aortic thoraco, abdominal, aortic aneurysm. Sometimes on the part is, the first part is on the thoracal, but the second tears on the parts of the abdominal.
Yeah. Yeah, it's a tough question. So the patients with it's like a thoraco-abdominal aneurysm. So the tear is from the sections involving the proximal tear and then distal.
The proximal tears is on the thoracic, and the second tears on the abdominal part.
Okay.
Which one involving like a mesenterical or truncus or something like this, the branches.
Yeah, yeah. So from what I know, so we have to cover the primary entry tear first, and then we saw after the intervention, is there any embolic in the distal part? If there are embolic, because if we close the primary entry tear, and then there will be no flow over there. So we hope so the tear will close, and then the second and third tear will be the re-entry for will be the re-entry. So we don't have to close until the distal, very distal parts, because it will be too long stand. But it's in my opinion. I will ask Dr. Suko.
So I think it really depends on first the anatomy of the dissections and aneurysm. Which includes the primary antitear, the secondary antitear, and the branches. So if we have a very large primary antitear and very minor secondary tear, then definitely we will go only to close the primary antitear. But sometimes they also have aneurysm below. So we extend the stent distally with the cautions that the risk of paraplegia is higher in those patients covered with two stents or stents longer than 200 mm. So in this case, we have to be ready to manage the blood pressure, and sometimes we do with spinal drainage to prevent paraplegia from these patients. In case we have to put more than 200 length of stent graft, or in case we have to use 2 stent graft. So that is our policy in the some developed countries. They don't want to do stage T4, so they just do all the way from left subclavian to above the celiac trunk.
Yeah.
So they regularly put the patients on blood pressure watch and spinal drainage to prevent from paraplegia.
Directly put the long
Yes.
stent graft. Thank you.
Dr. Iwan is here. Maybe you can join us for discussion.
Yeah, Dr. Suko, that's very interesting question from Dr. Isman when I left the CAT lab. What actually happened with this stent graft, the proximal part? Actually, this is the first time for me
Yeah.
to have a delay open of the proximal part of stent graft. Why it happened? Because of very steep angulations,
Yeah.
almost 90 degrees like this.
So what did you do to
Kang,
open,
who-
Dr. Iwan?
Dr. Suko also decided the stent, nothing, with the Professor Kang. The proximal part fully deployed when we open up the delay deploy. Then it takes some time because of the very steep angulations. Then we started waiting, and then what should we do? If let's say we have a long waiting, more than 10 minutes, such as like that, because of the blood flow to go to the cerebrovascular artery will be higher. Then number one is try to open up by pulling out the olive tip, number one. Number two, if let's say we can pass this one and there is still it's not fully deployed, we put a balloon. Because, but initially we should take out the olive tip, otherwise we cannot pull a balloon.
Yes.
And the other option is to put another wires coming from the right groin, and we put a balloon in, deploy, and then take out the olive tip. The olive tip is the tip of the proximal part of the stent graft. This is normal way we can do, just open up, just pull out the olive tip, and it will be open later on. It takes some time.
Yeah.
If it is not fully open, another option is put the balloon, the posterior balloon. We are, yes.
So,
Yes, so we are ready for it actually.
so,
Either from the right brachial or from below.
so the
So I think
later,
that's the answers.
from the other side of the groin would be easier, I think,
Yes,
Dr. Iwan,
yeah,
because the
you're right.
The,
So that's why we are ready with actually with 3 or 4 puncture for the peripheral works. Right groin, right brachial, left brachial.
any questions from the panelists and the audience? We have surgeons around. Any comments from Dr. Sugisman? Maybe you have some comments or some point of discussion?
Maybe Dr. Suko, one more, if there's no questions. Because a lot of audience is also from general cardiologists, and one of them also asked me about anticoagulation or antiplatelet after TVAR or EVAR. Do you have any insights on that?
Yeah, generally for TVAR and EVAR, we don't regularly put the patient on antiplatelet. We use anticoagulant during the procedure. But in this particular patient, because the patient have carotid to subclavian bypass and previous PCI, the patient have antiplatelet.
Okay.
But normally we not routine.
No, unless we do bypass or penetrations or chimney, then we will put the patient with antiplatelet.
And for how long? Just 3 months, 6 months?
Indefinitely.
Oh, indefinitely. Okay. Thank you.
Yeah, Dr. Kang is here. Please join us.
Dr. Suko, maybe one more issue about this TIVAR treatment for aortic aneurysm. For aortic aneurysms, about the issue of TIVAR now for GKN patients, for BPJS patients now, BPJS cover these procedures, but maybe only one stent graft. But I think with this coverage from BPJS, this procedure will massively done by our cardiologists. But some of your patients, not your patient, but every after TIVAR patients come again with I don't know, stenosis or others, so should perform another TIVAR. What do you think about this situation? What actually happened? Patients go to another TIVAR or the re-TIVAR for this kind of patients?
Yes, maybe later Dr. Iwan and Dr. Kang could help me. But we know endovascular intervention is a less invasive option as compared to open surgery. And it reached similar outcome to open surgery in terms of EVAR, but superior outcome as compared to surgery in descending aorta. For ascending aorta, of course, surgery is the first option. However, as documented in many trials, re-intervention for endovascular treatment is much higher as compared to open surgery. That is why I think it is logical to have a re-intervention from endovascular treatment. It might be endoleak, it might be migrations, it might be thrombosis. So there are many complications that might occur after endovascular intervention that requires re-interventions. So I think once in a lifetime procedure is completely irrational.
Suko, I want to ask to Professor Kang.
Yeah.
Professor Kang, based on your experience in our case before, there are a chance of developing the type 2 endoleak in the future. And in your opinion, how high to develop this endoleak because the subclavian artery has a forward flow anterior flow?
Right there, you mean the type 2 endoleak from left subclavian artery? There is very tiny, actually. I can say this is the almost type 5 endoleak. So type 5 endoleak definition is invisible endoleak, but it was visible, but very tiny. Well, anyway, the pressure will transmit it from the aortic lumen to the false lumen. That's why the patient have the symptom, and then the false lumen contrast enhancement was seen. There is a chance of the type 2 endoleak from left subclavian artery because there was the endoleak. So we didn't embolize the endoleak point directly. We just cover the proximal, and there is a still flow in the left subclavian artery. So I think there should be a chance of the recurrent type 2 endoleak from left subclavian artery. But rather simple to manage it. When we see the type 2 endoleak, just place the plug in the left subclavian artery origin. Then just sacrifice the left subclavian artery stump, then the problem will be solved. That is simple, rather simple, from left brachial artery, puncture, the A-French puncture and place the plug, a rather simple procedure. Actually, the lifelong surveillance follows the regular follow-up strategy.
Right. We still have 13 minutes? 13. 1, 3. So I have questions for Dr. Kang and Dr. Iwan. Looking at this patient initial aortogram, we can see that the amount of endoleak is much smaller as compared to the CT scan.
Yeah.
So I would agree that this patient required intervention currently because the endoleak is symptomatic.
Very symptomatic.
But if we only have the data or without complaint that the endoleak is decreasing from the last CT scan to the aortogram, would you still consider conservative treatment for this patient?
Yeah, the most important thing that you mentioned about symptomatic endoleaks, even very sluggish flow of type 1A leaking, but the most important thing is the symptoms. Once the symptoms develop, and then the size is still 7.5 something. It is tend to be increasing within the weeks or months. So that's why we decide to treat any symptomatic type 1A leaking as soon as possible rather than waiting for a couple of months. I think that this is what we have already discussed, and we decide to do put another cover stand to exclude the leaking. This is the most important point. And then, of course, we have a lot of options actually, Dr. Suko. Previously, we discussed whether we just put a cover stand, number 2, or put a glue or password plugs for this one. But we decide to perform a stent graft. But we still consider there is a type 4, the porosity leaking, which is probably coming in the middle part. We can see the first and second angio. So that's why it is a reason why we put a cover stand rather than to put a plug, vascular plug or glue.
Yes, actually, I think this is very educational case. Well, the original location of the anterior is very close to left subclavian artery, so it is very difficult to treat the type B dissection because this is a chronic. So if the lesion is acute or subacute, when we place or exclude the anterior, the dissection flap moving backward, so the anterior will be sealed completely. But in chronic case, the dissection flap is fibrosed, so it doesn't move back immediately after the stent graft placement. And the thing is, actually we assume that the endoleak amount is not quite big because the forced lumen thrombosis is already achieved in the distal part.
Yes.
There is no contrast enhancement in the distal part of the forced lumen. Only proximal part of the forced lumen is enhanced, but the size of the forced lumen was quite big, and also it looks tense. That means there is a possibility of the forced lumen rupture, so that's why we want to treat the patient. And there should be many options for treating this patient: direct embolization and proximal extension and so on. But the reason why we choose proximal extension, even though we do the embolization directly, so that's not the permanent. Actually, the anterior, the most important thing is to exclude the anterior, the inflow of the endoleak. So the ideal treatment method is to covering the anterior with a stent graft. That's why we choose the proximal extension instead of the direct embolization.
Right. Any other comments? So we are 8 minutes due. So probably one last question. So Dr. Iwan exposed the difficulty of choosing the diameters because probably there's a discrepancy between proximal and distal diameter, Dr. Kang. So we noticed that we are using the tapered stent graft.
Right.
So I think it is more physiological. So my question is, how often do you use it, the tapered stent graft as compared to the regular stent graft currently?
Usually, when the diameter difference is more than 10% or 20%, so we better use the tapered stent graft. Otherwise, we can use the straight stent graft. And the diameter, actually, if we choose too big size, it can be folded inside of the stent graft. When we place the stent graft in the natural aorta, the aorta will expand until a certain diameter, because the stent graft push out continuously. But the thing is, the tandem stent, the stent graft in stent graft is much more complicated. If there is big size mismatch, the folding of the second stent graft will happen more frequently when we use the stent in stent. But we need to choose the diameter, maybe 15 up to 20%, not more than 20% or 30%. If we can choose more than 30%, mostly there is a folding inside of the previous stent graft. So the choosing appropriate size is one of the most important factor in successful endovascular treatment.
Yeah. So we have still 6 minutes.
Okay, Dr. Suko.
Yeah, Dr. Isman, go ahead.
Yeah, Dr. Suko, regarding the TIVA procedure, the access 22 friends, very big device access for these patients. So what the strategy to close the access to save, to reduce the complication of hematoma with the glue or with the ProGlide? Is there any difference, 18 friends to 22 friends with 2 or 3 ProGlide or others? Maybe you have a comment, Dr. Suko, Dr. Suko.
Yes, of course, prior to the intervention, we have to carefully analyze the access as well. So what we need to know is the diameter, of course. If the diameter is too small, then we might have to ask the surgeon to open for us, the cut down, or even to make a conduit if the iliac artery is too small. The second is calcification. We cannot put the ProGlide properly with the very severe calcifications. Those two are the main concerns of the access. But if there is no concerns of the diameter and calcifications, we routinely use ProGlide with the maximum diameter of 21 French sheet. We use several times the 22 French sheet with closure device, but the actual recommendation for large closure device is 21 French. So because this patient required a 22 French sheet diameter, then we open the access surgically. Or we do sheetless.
Right, actually, these days, the demand of the large closure device is quite big because they do many procedures with a big device, such as TAVI, TAVR, and IVAC, and impella procedure, and stent graft. Actually, endovascular procedure is getting popular. And we have now many big closure devices, but is not available everywhere. In only, well, a few countries, they can use big closure device. Well, when I use the arteriotomy, we can introduce quite big delivery system through small artery. Even though the artery size is rather small, such as 6 or 7 millimeter, we can introduce 7 or 8 delivery system when we use arteriotomy. But it is not possible for the percutaneous. So if we want to use 18 French or 21 French larger delivery system for smaller access, we need to do the arteriotomy. So arteriotomy these days, in the past, actually arteriotomy is not very feasible, but while we have very good surgeons, and arteriotomy is rather quite simple procedure, so we can use arteriotomy for such a case. But the pre-closed device can be used for the healthy, natural artery for large size delivery system these days.
Okay, we are almost 1 minute to the concluding time, so I would like to close this discussion. I would like to thank the operators, Dr. Iwan, Dr. Tovan, and Dr. Diki Alighieri, as well as the panelists and our guest lecturer, Professor Kang, Dr. Isman, Dr. Suci, Dr. Rini, and Dr. Noel. Thank you very much for your attention.
Let's
Ladies and gentlemen, as the second session will be parallel, there will be lecture and live demo and discussion on minimally invasive surgery with valve clamp in high-risk patients and parallel with live demo and discussion on leadless pacemaker. The second lecture will be delivered by Professor Lai Wei. He is the Deputy Chief of Department of Cardiovascular Surgery in Zhongshan Hospital, Shanghai Medical College, Fudan University. And then the live demo will be led by Professor Lai Wei himself with Dr. Amin Chubandi as the operator and co-operator. And for the operator of TEE will be led by Professor Dr. Amiliana with Dr. Dong Lili. And for the second lecture will be live demo and parallel with live demo discussion on leadless pacemaker with Dr. Suni Budi Raharjo as the operator, and the moderator for this live demo is Dr. Muhammad Yamin. Ladies and gentlemen, for the panelists of minimal invasive are Dr. Sugisman, Dr. Doni Firman, Dr. Dafsa Arifah Juzar, Dr. Rina Aryani. Before we begin, allow me to read our moderator CV. Dr. Diki Aligeri is the thoracic cardiac and vascular surgeon in National Cardiovascular Center Harapan Kita. Expertise in aortic surgery intervention on off pump coronary surgery. Ladies and gentlemen, please welcome our moderator for this session, Dr. Diki Aligeri.
Okay, good morning, ladies and gentlemen. Thank you to join our, I think our second meeting in this today. Our meeting today is about the minimal invasive surgery with valve clamp in high-risk patient. As we know, our lecturer today, our distinguished lecturer today is Professor Lai Wei from Zhongshan Hospital, Fudan University in China. Professor Lai Wei, current position is the Director of Minimal Invasive Cardiovascular Surgery and a member of Chinese Society, Chinese Association Cardiovascular, and Chinese Committee of Minimal Invasive Cardiac Surgery. The lecture will be in 20 minutes, and Professor Lai Wei, the place is yours.
Thank you all. Thank you, Indonesia. It's my first time in this beautiful country. I'm Lai Wei from Shanghai Zhongshan Hospital. I'm a cardiac surgeon, and today I will introduce a new transcatheter H2H device called valve clamp. Sorry. Join audio. Okay. this, make this small. Yes. And this device is made in China, called the valve clamp. It has approved by Chinese government. It's simple, straight, and it's a design. It's from here to here is 2 centimeter, and it's have a front clamp and a rear clamp. It's not like mitral clip or not like Pasca. It's a new design and have 3 types. And firstly, we insert it's a transapical device. Firstly, we advance the 2 clamps into the left atrium, then pull back. The upper clamp is still in the left atrium, and the lower one down to the ventricle, and clamp and release. So it's simple. It's not like a mitral clip because it has the pass route is very short and straight. So it's easy to adjust the position and the one-to-one transmission of the movement and a larger space to capture the leaflet. So the efficiency of this device is very efficient, and the option is to perform under the guidance of echo, no need X-ray. This is the video, and we cannot move. I cannot move the bar. Cannot move the bar. Oh yes, okay. Yes, I have just said, and it can not only use in A2, P2, but also A1, P1, A3, P3, or even C1, C2. But you know that it's very difficult for C1 and C2, but we have done. It's the first in man, 2018 in Shanghai. Dr. Ge, cardiologist, our director, and Dr. Zhou, Dr. Pan, they all cardiologists, and it's me, my assistant cardiac surgeon, Dr. Yang, Dr. Pan, the echo physician, and Dr. Guo, anesthesiologist, and Dr. Zha, OR. Okay. We have published many publications, papers, include animal, first in man for degenerative mitral regurgitation, and 1-year follow-up, and this year, first in man for functional mitral regurgitation. Yesterday, we have performed the first case in Indonesia in a hospital, and it's a very difficult DMR patient. He is the 84 years old male and 5+, very severe torrential mitral valve regurgitation, and not only P2 flare, A3 is also flare with rupture cord. So we call that it's a red zone. According to the difficulty for TIA, we can divide into green. You know that you see that it's P2 prolapse, a rupture cord, and it's A3. So it's relatively difficult. We call that red zone. The green zone is ideal for TIA. The yellow zone is a challenge, but the red zone, we don't think it's very suitable for TIA. Maybe it's suitable for cardiac surgery, but yesterday's patient is very old, so you can see that he is a multiple segment prolapse and cord rupture. So firstly, we captured with the first clamp. Sorry, you can. Oh, maybe something wrong. Okay. With the slides. Restart. And with the with your team, Dr. Amin and anesthesiologist Echo. Okay. Sorry. Restart or restart program. Because it's, many videos. Huh? Yes. Yes. Uh-huh. And altogether, we put two clamps. First in the A2P2, and then still 2 plus regurgitation. Oh no! I cannot move it. And then we put another put another clip to the A3 and P3, and the jet, the regurgitation jet disappeared, and the mean gradient is only 2 millimeter. Yes, maybe the video is too heavy. Yes, please. Okay. Sorry. The next one. The next slide. Next one. Yes. The next one. I say. Yes, here. Next one. Next. Yes. Yes, it's the yes, I can show you. Yes, it's two clips here, and also a mild or trace regurgitation. Next one. Move to next slide. Yes, we have last year's TCT, September, in United States, we have reported our 1-year result of the multi-center clinical trial of TE with valve clamp. Next one. Next page. Yes, we have inclusion criteria and exclusion next. Altogether, 102 cases. Next. The average age is 74. All moderate to severe or severe regurgitation, and most of them are A2P2 because of the inclusion criteria is very strict in clinical trial. Next. The acute procedural success is 97%, and we can divide into 2 parts. The first 50 cases and the later 55 cases, and we can see that the 1-year follow-up, the effective rate at 1 year, the earlier 55 is 80%, and the later 52 cases improved to 96%, because we are cardiac surgeon. Before this clinical trial, we don't know how to do TEER. So we have a learning curve, so we divide it into 2 parts. Okay. Next. And the catheter catheter operation time is only 20 minutes, only 20 minutes. And the skin to skin, because we should make a small incision from the left chest, the intercostal space, the fifth or the sixth intercostal space. So the skin to skin time is only 1 hour, and 88% cases were just implanted only one clamp, of course, we know that it's a very strict clinical trial, and we also choose the green zone patient. Next page. And the 1 year follow-up, the mitral regurgitation rate significantly decreased. Next page. Next. Next. Have a result. EF. Next. And this year we published our 3 months follow-up from functional MR. Next. And also the result is good. The device success is 100%. Next. This is the case for AFMR, the atrium FMR, 70 years old patient. Next, the very severe MR A2P2. And we use a mesh ball to introduce the sheath to the left atrium. Then we release the clamp. Next. 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 The result is good. When the patient discharged, the only trivial regurgitation. Next. Another patient is ventricle functional MR tethering, A2P2, severe tethering to the ventricle. Next, the EF only 36, mesh ball and the capture leaflet. Next, the result is good. And we have done functional MR, more than 50 cases with this device. Next. We can a combination of 2 Chinese-made original transcatheter instrument. For example, this case is a severe aortic regurgitation and severe mitral regurgitation, and we use J valve and valve clamp. Both of them transapical. Next. Totally, we have done more than 10 cases with these 2 combined. Next. Next slide. Yes. Oh, next. Is a demo. Next. Now the J valve have a transfemoral version. It's a 2nd generation, and we have finished the clinical trial. It's for aortic regurgitation, not for stenosis. Very useful. Next slide. We have published the paper in Ics-Hk. It's a 1-stage TAVR and TEER for double valve regurgitation. Next. Yes. Next. It's a aortic regurgitation. Next page. It's a mitral regurgitation, and it's J valve, transapical, and 3 filler or locator. And we put the 3 locator down to the 3 sinus and open the valve. And it's very safe for regurgitation. Next. And then still a mitral regurgitation, and we decide to do TEER with valve clamp. Next. Yes, it's a valve clamp. Next. Yes, next. After operation, It's a valve clamp. It's a J valve, so there's no mitral regurgitation at all. Next. So one approach to, and we have done three valve, J valve for AR, valve clamp for MR, and the Lux valve for severe TR, tricuspid. All of them from China. Next. It's Lux valve. I had get the breakthrough device by United States FDA in 2021, and estimated to be approved by Chinese government in 2014, the next year. Now the first generation version is trans right atrium, and we have also finished the transjugular vein, right jugular vein version, second generation enrollment. Next slide. Yes, it's the second generation. Next. This case is a 66 years old patient. Next. EF is only 29%. Severe AR. Next. Yes, severe MR and severe TR. Firstly, we do transapical TAVR with J valve. Next. Just the same. Next. You can see the last slide. Oh, next. No problem. Next. Many video. Next. 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 We cannot see the video. It's a we can see only one. It's a before a release of the Lux valve. Yeah. Next. If you are interested, and after the lecture, I will show you in my computer. Next. Oh, the last slides. We cannot see the three devices in one picture. Next. The valve clasp is a Hanyu Medical. They also developed the second generation transfemoral clip. Next. Oh, thank you.
Okay, thank you very much, Professor Lai Wei, for your interesting presentation, and congratulations for your result.
Thank you.
Okay. First of all, actually we all have news that the patient is already prepared in the OR, and someone will guide you to the OR. Like now. Dr. Amin also in here.
Dr. Amin is here, yes.
Okay. With us here, Dr. Doni Firman and Dr. Rina as an expert in structural heart diseases. I understand both of them have any comment about your presentation today. Please, Dr. Doni Firman and Dr. Rina.
So thank you very much. It's really fascinating lecture, and then I'm enjoying so much. I'm a cardiologist, interventional cardiologist, and then also my friend Dr. Rina is echo cardiologist. She's very expert as well. So for the last, I think, 8 years, we also routinely doing mitral clip procedure in our lab. But I must admit that the time to do the mitral clip is really long sometimes. If we are lucky, we can do it in 3 hours. But if we struggle, so it can be 7 hours. It's a long procedure. So it's really good to see that you can do it in very fast way. And then I think it's also will help the people and also us as a clinician to take care of our patients. So the thing that I really enjoy is that in mitral clip procedure in transfemoral, sometimes it's difficult to find the right spot to the first transeptal to do a good transeptal position. And then second, to do the angulation from the left atrium to the orificium of the mitral. Sometimes it's challenging, so it took time. So by doing this procedure, I saw that it can bypass the time, it can reduce the time. So my question will be how you do it in the transeptal, transapical puncture. How you do it in the, you guarantee that it will be in the coaxial with the mitral. I know STE will help, but sometimes the anatomy is not really easy. So how you do it? Thank you.
Yes, thank you. Thank you for your question. Firstly, we should choose the patient, and before the procedure, before we select this patient for valve clamp, we should see the CT scan. If the patient's left atrium is very big, and maybe they are push the ventricle to maybe to left, to the right, to the up, we cannot, if we judge, we cannot find the right place to puncture, we will give up. We don't choose this patient. So this is the first. And the secondly, before operation, we will do the TTE. After anesthesia, we should use the TTE to find the right place in the fifth or the sixth intercostal space. For example, yesterday's patient, we find it here, and today's patient and next patient, we will find the left side. We will use the TTE. So we only need a very small incision, only with 2 fingers, a very small incision. And after we open the pericardium, we will use finger test. We will finger to test the apex to find the right place. This is a mitral. This is a mitral. We should find a puncture site just face the center of the mitral annulus. We cannot find this place. We cannot find it. We should find the right place, just straight to the center of the annulus. Then we will. I think if we find the right puncture site, the procedure have success, half. So the 3 steps. Now first we should do the CT scan. About maybe 5% or 10% we will give up because of this reason. But most of the patients we can do TEER procedure with this device. As you just mentioned, very simple and save time. We can do no more than 2 hours. Most of them 1 hour. No more than 2 hours. For example, yesterday's case is relatively difficult, and we perform maybe 1.5 hours. And today's patient is also difficult. You choose 2 cases very difficult. The width of the prolapse of leaflet is very wide. The next patient, the width is 23 millimeter. So if there's I think today's case will use 2 clamps. We cannot plant 1 clamp to kill a so wide lesion. Okay? And you will see, I think maybe we will finish in 1.5 hours. Okay? Thank you.
Yeah, thank you. I also impressed by the presentation. I think it's very insightful. Regarding Dr. Doni question about the position of the puncture transapically, if the lesion is not on A2 or P2, for example, it's isolated in scallop 1 or scallop 3, do you change the position of the puncture or it's still in the center? And then just for curiosity, how many clamp have you ever tried to use in a patient? I know by adding more clamp, we can create a mitral stenosis. So how many clamp have you ever used?
If this patient is not A2, P2, some patients even C1 or C2, I don't think we need to change the puncture site. Most of the patients is the same puncture site. We can from the center to the left to the right, because firstly, even the patient is C1 or C2 or 10 or 30, we should firstly insert, advance the instrument through the center of the mitral, because there is no cord here. And if we firstly advance the device to the left or the right side, maybe there is some cord and maybe have twist with the cord. So firstly, we should advance in the center. Then we will put left side or right side. The first question. The second question is about maybe cause stenosis. And I have done more than 100 cases with valve clamp. About 90 or 80 or 90% is only one clamp, and the rest of them two. No three. No need three. A very impressive case after operation. The gradient is developed to 8. The mean gradient, only one case to 8. So I think maybe some the moderate stenosis, but the rest of them, the gradient is only 3 to 4. Yes, this patient, the annulus is very big, so even we put 2, after operation, the gradient is only 2. Okay, so I think it's safe and efficient. Okay, maybe it's time for the procedure, and I will go to the operation room. Okay,
Thank you very much.
Thank you.
Good luck
Thank you.
today.
Yeah.
Ada yang bisa bantuin? Bentar aja. Ada. Oh, itu ada. Oh. Tinggal kita jawabnya gimana? Kalau audiens nanya jawab. Ini ada audiens yang mau diskusi atau apa? Siapa tahu kita bisa ini.
Oke, kita diskusi aja kita sama kita. Sebelumnya kan kita sudah mengerjakan minimal invasif juga ya di cardiac valve ya, kalau saya tidak salah sih. Tapi kita tidak menginsersi device kan di sana ya, repair seperti biasa ya. Kira-kira dari segi outcome bagusan mana ya, kita pakai device ini atau pakai reparasi yang seperti kita biasa lakukan?
Terima kasih Dr. Doni. Jadi waktu kita dulu belajar mengenai surgical management dari valvular disease untuk mitral valve, prinsipnya kita harus menyerang atau kita harus mengatasi leafletnya, cordnya, dan anulusnya. Gitu. Nah, berdasarkan prinsip itu aja, sebenarnya prosedur ini dia cuma nyerang leafletnya aja. Jadi saya nggak tahu untuk jangka panjangnya. Tapi rasanya kalau jangka pendek atau untuk pasien-pasien yang high risk mungkin membantu pasien ini. Cuma saya kurang tahu, nanti kita harus lihat jangka panjangnya dok. Gitu. Karena berdasarkan prinsip awalnya agak nggak memenuhi itu semua. Gitu dok.
Kalau kita lihat kalau degeneratif, berarti kan kalau kita memperbaiki mitralnya saja, kemungkinan dia outcome jangka panjangnya lebih baik ya Rin ya. Kalau fungsional saya nggak, mungkin lebih bermasalah ya. Saya nggak tahu gimana Rin, karena kalau kita lihat trial dari mitral, mitral clip, memang tuh yang lebih meyakinkan pada degeneratif ya. Dan memang mereka juga mensasar hanya leaflet aja kan. Mereka tentu nggak bisa memperbaiki kornea dan lain-lain ya. Tapi outcome-nya ternyata cukup baik ya, bukan hanya surrogate seperti pengurangan MR, tapi juga outcome klinis gitu. Saya kira sih untuk degeneratif mungkin ya, menurut saya sih menjanjikan juga sih. Tapi saya nggak tahu ya, kita butuh data yang lebih panjang sih.
Kalau lihat bagaimana dia mengerjakan, sebenarnya kan outcome-nya harusnya akan hampir mirip dengan yang mitral clip transkateter kan ya dok ya. Jadi harusnya yang ini outcome-nya akan kita temui sama. Berarti untuk degeneratif harusnya lebih mirip outcome yang kita temui nantinya. Karena memang yang kalau H2H repair ya memang dalam tanda kutip salvage ya, atau bailout untuk yang tidak memungkinkan untuk dilakukan repair secara penuh. Jadi kan memang hanya nge-grip leafletnya. Jadi untuk kasus-kasus degeneratif di mana dia terindikasi untuk mitral clip yang transkateter, sepertinya outcome-nya akan sama. Dan kalau untuk yang fungsional, sepertinya juga yang di mitral clip kan juga dia akhirnya dia memilih functional MR yang mana yang sebenarnya benefit untuk di mitral clip, atau yang kalau misalnya sudah terlalu advance functional mitral regurgitation-nya pun berdasarkan studi-studinya juga nggak terlalu bagus kan ya dok, hasilnya kalau EF-nya sudah sangat jelek, pasiennya PH atau mungkin tentingnya sudah sangat tinggi, ya mungkin yang model H2H repair ini juga outcome jangka panjangnya untuk yang fungsional jadi tidak baik. Tapi kalau kita bisa memilih pasien yang tidak dalam kategori yang sangat severe, ya mungkin akan menghasilkan hasil yang sama juga dengan H2H repair yang transkateter. Jadi kalau untuk fungsional menurut saya pemilihan pasien yang akan jadi sangat penting. Kapan kita memilih pasien yang tidak terlalu berat atau tidak terlalu advance sehingga masih mempunyai manfaat untuk H2H repair ini dok kayaknya.
Mungkin saya tambahkan ya bahwa minimally invasive surgery yang selama ini dilakukan itu sebenarnya secara prosedural bedah sama dengan conventional surgery. Bedanya hanya di aksesnya aja, ada yang full sternotomy, ada yang mini torakotomi. Tapi sebenarnya prosedur infarktnya itu sama dengan conventional surgery. Jadi seperti kata Dr. Diki tadi, sebenarnya secara long term hasil daripada yang minimal invasive surgery yang klasik itu akan sepertinya jauh akan lebih bagus dibandingkan yang teknologi yang berkembang saat ini, karena sepertinya teknologi yang berkembang saat ini itu hanya seperti kosmetik ya mungkin ya. Jadi dia di-inspire dari P2, lesi sentral gitu. Jadi H2H alveoli technique gitu ya. Inspire-nya kan semua dari sana, dari mitral clip. Kemudian berkembang mitral clip, kemudian sekarang valve clamp atau mitral clamp ini. Jadi sebenarnya dia hanya mampu mengattach leafletnya aja. Jadi memang akhirnya untuk indikasi lebih ditujukan kepada pasien-pasien yang high risk patient untuk mengurangi kemungkinan terjadinya morbiditas dan mortalitas pada pasien dan bisa mengurangi simptomatik yang ditimbulkan oleh pasien dengan melakukan prosedur itu. Walaupun mungkin secara komprehensif tidak mengembalikan kompetensi daripada valve mitral tersebut. Mungkin demikian.
Terima kasih Dr. Rina, Dr. Doni, Dr. Sugisman. Tampaknya tim dari kamar operasi sudah siap untuk presentasi. Silakan.
So here's the area. There is size.
Good morning, Professor, doctors, and all my colleagues. My name is Rizka. I'm a cardiothoracic and vascular surgery resident in University of Indonesia. Today, I would like to firstly present the data of our patient who is going to have minimally invasive surgery with valve clamp. The patient is 80 years old female who is experienced worsened shortness of breath for the last 4 months. The complaints were accompanied by fatigue and also dyspnea on exertion. Patient also felt tired easily with moderate activity and was classified as type 2 heart failure using New York Heart Association classification. The patient denied any other chest pain or nausea and vomiting complaints. Well, the patient was firstly diagnosed with heart disease for more than 10 years ago, but the complaints are still tolerable, so the patient decided to take optimal medical therapy instead of intervention. Complaints of shortness of breath was worsened after the patient had experienced a COVID infection around June 2023. She was treated at the hospital for 1 week with moderate symptoms of cough and shortness of breath in the general ward. But after recovering from COVID, the complaints of shortness of breath tend to get worse. The patient then went to a cardiologist and was told that the heart valve condition was getting worsened. The patient then decided to be scheduled for a valve surgery using valve clamp. The risk factor of the patient was hypertension that was controlled by candesartan, and also the patient had asthma. The last episode of asthma was more than 1 year ago. And from the physical examination, we found a pansystolic murmur with grade 4, and the ACG shows paroxysmal atrial fibrillation. This is the laboratory findings of the patient. The complete blood test was found normal, and routine coagulation test, liver function test, renal function, and also blood gas analysis was also found normal. The patient was slightly hypopotassium and will be corrected intraoperatively. Screening tests and infection marker tests were also normal in this patient. This is the radiologic findings, the chest X-ray. It shows that cardio and thoracic ratio was 57%. The apex shows downward, and there is no infiltrate seen in the pulmonary function. This is the echocardiography preoperatively.
The length of the leaflet, the AP diameter, the linkage, the mechanism, and then the valve area.
From the echocardiography, we found the mitral valve got flail of P2 and P3 and also scallops of PML with ruptured chordae. There's severe mitral regurgitation with VCA 2.5 and vena contracta 1 centimeter. The error was 4.3 and the Vmax of the MR was 1.6. The mitral valve area was 6.89 and the regurgitation jet is central. The pulmonary vein systolic reversal flow is present.
This LIA appendage, this is ours. Oh, this is our here.
Well, for the conclusion of the transesophageal echocardiography preoperatively was severe mitral regurgitation due to PML prolapse and partial flail of P2 and P3 scallops with moderate functional TR or tricuspid regurgitation with intermediate probability of pulmonary hypertension. Patient got normal LV systolic function with EF 67% and global normal kinetic, and also good RV or right ventricular contractility. And there is also paroxysmal atrial fibrillation during the test. For the key clinical data of the patient got severe mitral insufficiency with tricuspid regurgitation moderate and also paroxysmal atrial fibrillation. Well, we will be discussing detail of the esophageal echocardiography with with Prof. Ameliana here. Please.
Hello. Yeah, hello, good morning.
Yeah.
Yeah, good morning. Can you see the echo picture here? Ya? Suara saya udah kedengaran belum ya?
Kedengaran dok, kedengaran. Cuma
Oh,
kita
okay.
belum lihat monitornya, Prof. Sorry, Prof.
Should I speak in Indonesia or in English?
I think
Indonesia?
you prefer in English.
Okay.
Thank you.
Okay. So at first, they asked me to perform transthoracic echocardiography to find the apex location, and then mark the chest of the patient, left side of the patient chest, where the apex is. And then we move to transesophageal echocardiography, and we evaluate the mechanism of mitral regurgitation. It seems that there is a degenerative severe mitral regurgitation caused by P2 prolapse and partial flail with chordal rupture. So what we should evaluate before the procedure is we have to measure the length of the leaflets, the AP diameter, and then we have to show the longest left ventricle exit from two-chamber view and four-chamber view. So in this procedure, we need 3D echo and multiplane, so we can show simultaneously two-chamber view and long-axis view. Yes. And this is the on-fast view of the mitral valve. You can see that the P2 is prolapse, wide P2 prolapse with some part of flail and chorda rupture. I will show you with the arrow here.
Yes, yes, I'm comfortable. Yes, I can hear. Yes.
Where's the arrow?
No.
So this is the
Yes,
lesion.
yes.
Yeah. Okay, this is the lesion. P2 wide, P2.
Left.
And then we evaluate the jet of the
Okay.
mitral. It's
Yes, big, yes.
eccentric jet, central jet. So we also measure the mitral valve area to be sure that after the clip was implanted, there is no stenosis. So this is the valve area, 4.85. More than 4, it's considered as safe. That's similar with the mitral tear, continuous edge-to-edge repair consideration.
还再往内侧一点。
So this is
这个人是很外的，这里哦，这个是。
Surgeon is looking for the position where the apex is shown better. So
下面好像就没有了。
make the incision at the area where the apex is really clear. So this is from transthoracic.
你觉得太外了这个？
Oh, sorry, I cannot translate their language. Okay, I think he has found the location, the correct location. Okay.
In the costal space. Yes. Thank you. Okay. No, this one. Yes, this one. Yes, thank.
Dr. Lai Wei or Dr. Amin, can you hear my voice?
Yes, it is a way. Okay. I can hear you.
Okay. Can you explain a little bit about how you choose the incision site in this patient?
Yes, I use the echo, TTE echo, to choose the right place. We can see the epic, and we can see the mitral valve plane. Mosquito, yes, here. Yeah.
Is that intercostal space? Fifth intercostal space, isn't it right?
Yes, the fifth. Oh no, we are. Yeah. We'll choose the upper one. And I use my finger, and I think maybe we choose the round intercostal space, and the upper one may be suitable. Retractor. No. This one. Do you have another? No. Here. Yes, here. Maybe here. Yes, maybe here. Yes. Here. Yes, here. Yeah. And what about yesterday's patient? Is okay? We make a small hole, and we can Touch, yes, it's place. It's the right place. Yes.
Okay. Dr. Laiwei, just in case there is some adhesion between pericardial, visceral and parietal pericardial.
Yes, we can divide it. No, small one, yeah. There is a many fat. Yes. Yes. Here, yeah. No need. Only one. Okay. We can remove the fat. Please help me. Yes. Okay. Oh, so many fat. This way. Yeah. Yes. Yeah. No. Yes. Okay. Okay. Yes. Another one. Yes, another one. Must go. Yes. Thank you. Yes. We will open the pericardium. Yeah. Yes.
Geometry compared to distribution.
Yes.
So if there is a wide different wide layer of product, we put the close lip at the center or just at the
Yes, I need a stay suture. The pericardial stay suture. Yeah. Pericardial. Yes. Thank you. Just same. Yes, stay.
big load there first. So this patient more one.
Suction. Yeah. Oh, no. Yeah, see. Another one, mosquito.
So, Dr. Diki Alighieri, we in the elephant EM, there is another in OT room, so you can share as a moderator with Dr. Yamin. Yes.
Okay, thank you. Ladies and gentlemen, Professor Lai Wei, we have in another session here, conjunction with our procedure, led by electrophysiology expert here. So we will come back to you, and please don't hesitate to say something if there is any point of view that it's very necessary for us to understand about this procedure. Okay, please, Dr. Yamin.
Thank you, Dr. Diki. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, all participants offline and those who are attending this meeting online. Today, I'm thankful to the organizing committee for assigning me to lead this session. As we know that the pacing technology has gained a lot of improvement or progress in recent years.
Yes.
And one of those is the leadless pacemaker. So we are going to see how this new technology is being implanted in our patient.
Maybe it's too short.
And
maybe it's too. It's okay. It's okay.
And to accompany and to have a deep dive discussion on this issue, I am accompanied by our distinguished panels. The first one is Dr. Budi Aryotejo from Fatmawati Hospital. The second one is Dr. Diki Hanafi from Harapan Kita National Heart Center. I think Dr. Diki is joining us online.
Yes, I'm here online. Hello, everybody. But I cannot turn on my video here somehow.
And the third panelist will be Dr. Rina. So without further ado, I would like to contact the CAT lab. If CAT lab is ready, then we are ready to have online discussion. Dr. Sunu, are you ready? Are you listening us now?
Assalamualaikum, Dr. Yamin and all of the panelists and participants. I can hear very clear.
Okay, Dr. Sunu, please introduce your team and your case. So we are ready to enjoy your procedure today.
Thank you, Dr. Yamin. Please share my slide. Yeah, again, thank you for the organizing committee to give an opportunity for us from the arrhythmia divisions to share about the live demo of the leadless pacemaker implantations. I'm here with Dr. Fandi Ahmad, our senior fellow. And next slide, please. Next slide, please. Yeah, this is our EP team. We are also accompanied by another fellow, Dr. Chandara from Cambodia, and Dr. Tia, our residents, Dr. Yoko, Dr. Natalia, Dr. Novi, our scrub nurse, Dr. Pak Adiles, Pak Wiji, kemudian, and then technician Ari, and radiographer Mas Dwi. Slide. Dr. Fandi will explain about the case, Dr. Yamin.
Dr. Sunu, we have some problem with the audio. Can you settle the problem first? We cannot listen and hear the case presentation.
Okay, please help the technical. Can you see the slide, Dr. Yamin?
Yes, it's very clear.
Okay.
I think the boss have to present the case himself.
Okay, because the problem with the microphone, yeah. So the chief complaint of the patient with, Mr. P, 72 years old with recurrent syncope, and he has controlled hypertension and the physical examination within normal limit. Slide, please. The ECG in the OPD is normal sinus rhythm. And then next slide. Slide, please. Yeah. But we also found that in another visit, the patient also has the atrial fibrillations. And the symptoms of syncope has no prodromal period, prodromal symptoms. So we decided and the first plan to do the Holter monitoring. Please show the slide.
Yeah, we are fortunate, Dr. Yamin and all of the panelists and participants, that based on this 24 hours Holter monitoring, we found the presence of sinus arrest. If we look at this, actually the calculation is 3.7 seconds, but if you look at the beat after the sinus arrest, it's not a sinus beat. So I believe that actually the sinus arrest is more than 3.7, probably about 5 or 6 seconds. Next slide. And also we also find several episodes of the sinus pulse and sinus arrest like this one. So sinus and then junctional. Slide. And in the Holter, we also found significant percentage of the atrial fibrillation, as we can see here in the Holter tracing. Slide. And we performed the echocardiography, and we found the patient have a normal ejection fraction of 63%, normal valve, and mildly dilated left atrium. Slide. The laboratory also have no significant abnormality, so normal laboratory finding. Slide. So we diagnosed the patient with syncope, recurrent syncope, due to the sinus node dysfunction and the presence of paroxysmal AF and controlled hypertension. Slide. So we decided based on the guideline. Of course, we can discuss about the choice of the pacemaker, Dr. Yamin, but we decided to implant a permanent pacemaker. At this time, slide, we implant a leadless pacemaker. The name is Micra device pacemaker. You can see here that the next, yeah. You can see, in the box, that the size of Micra is the same size as the coin here. Maybe, yeah, that is the size, the actual size of the Micra, right? The opportunity to have this Micra or leadless pacemaker is the potential to increase satisfaction of the patient because there is no scar, no bump, and no visible or physical reminder, and minimally invasive procedure, no surgery, and potential for fewer post-implant activity restriction. Next slide. And this is the benefit of the leadless pacemaker. The pocket-related complication is much lower, and also lead-related complication. Slide.
Dr. Sunu?
Yeah, please.
We apologize because we are having concurrent lapse transmission from the OT, so they would like to show us a very critical moment of this procedure. So I will hand over to Dr. Diki first, then we'll get back to you, and please proceed of the procedure.
Okay. I will proceed with the procedure. Thank you, Dr. Amin. Okay.
Okay, Professor Lewey, please, we show you on screen. We understand that you're going to show us how you pick your puncture site on the left ventricle. Dr. Lewey, do you hear my voice?
Halo, 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 nggak kedengeran? Oke.
Oh, Dr. Amin.
Dr. Ige?
Yes,
yeah, Dr. Amin here. Yeah, that's the finger test. First, to make a site for the puncture at the apex of the patient. So we must try to find a good puncture here because it's very crucial. It's very crucial. So the coaxial of the valve clamp can be reached from the apex to the middle of the valve.
Real, yeah. Okay.
Okay. Now we make a tabak sac, a pull string stitch at the site of puncture. Can you hear my voice, please?
Yes, this is Donny here. So yeah, we see the from the echo, the shadow of the fingers, the thumb.
Yeah.
Yeah. So for the committee, Panitia, can you enlarge the pictures of the echo so we can understand the imaging? The echo can be enlarged, please. Yes. Yeah, maybe both. I mean, echo and the visual from the OT. so we can understand. Can you do both picture, one echo and then one from the from the OT? Right now we just only see yeah. If you can enlarge the echo, it's gonna be good. Yeah, but it's okay if you cannot.
Yeah. We make two stitch here at the puncture site.
Because they're too fat, so I make sure
A lot of
everyone should
at the surface of the
to the muscle,
the surface
not
of the
only to
heart.
the fat. You are deep.
Yeah, must deep.
So maybe Dr. Mill can enlighten us how can we make sure that we get the true apical from the transesophageal echo image.
So I give Dr. Mill. But
oh, Prof. Mill, I'm sorry, Prof. Mill.
Oh, oke, silakan.
Yes, cut.
Heparin dong.
Hey, no. Yes. The second one.
Oh, belum, kita belum mulai. Enggak, belum ada yang Yeah, sorry, perhaps I just want to show that what we can see from the echo. Can we do that? Yeah,
you're live.
The finger is pointing. Which picture is the finger pushing the apex? Not this one. I think, no, it's measuring the... this one. So, can you see the echo TE here? And then this is the, this is where we can see the finger of the surgeon pushing the apex.
Yes, here.
So
That's the
this is
direction.
how, if we already in the correct position, then we tell the surgeon. But according to the echocardiography, cardiologists here, the location should be a little bit here. Yeah. So we just inform the patient. It's for mitral clip, it's just like finding the right place for puncture. So in this procedure, it's finding the right place for puncture as well. But the area is the apex of the left ventricle, not interarterial septum.
Heparin.
I think
Heparin.
that's all. We'll wait for another.
What's the weight? The weight of the patient?
Step.
Prof. Ameliana, how many times did he try to choose the place in apical? Change many times or just once and then it's confirmed?
No, for yesterday patient, I think it's easier to find the apex, but now it's rather difficult because of the geometric change, distortion of this patient. So it's rather, he tried a couple of times, but then he find the right place now. So the most important thing is that we look at the longest left ventricle axis perpendicular with the mitral valve plane, mitral valve area plane. So now, what is he going to do now? Oh, now he's begin to puncture, then we can see, okay, you can see the finger test again over there. That's the right place. You can see from the 2-chamber and 3-chamber of the left ventricle. So that is the right, correct place. So he's now going to puncture.
Sorry, Prof. Ameliana, can you move the picture to the upper side of the whole frame because it's.
Sorry, PIC. Gimana tuh mau pindahin?
Monitor di kita terhalang dengan gambaran interoperatif, dok.
Oh gitu, gambaran echonya ketutup ya?
Gambar echonya tertutup.
Dok, itu gambaran itunya mau dihilangin bisa nggak?
Iya, dari OK. Dikontrolnya dari OK itu.
Dari OK ya.
Tolong pindahin ke atas bisa harusnya.
gambaran itunya tuh dipindahin ke atas. Di final monitor. Itu tuh gambaran lapangan
Di monitor
operasinya dipindahin ke
final
atas
monitor
supaya
di
gambaran
OKA tolong dipindah.
ekokardiografinya bisa jelas. So he's going to puncture. So we just wait.
Dr. Amin,
You can see
how
the,
many heparin
here.
we use in this procedure?
Dokter Amin, heparinnya berapa? Heparinnya berapa nih? Dokter Diki nanya. So you see that the needle is already goes through the left ventricle and then mitral valve and then in the left atrium.
Kilo 1, yes, maybe 100
Gambarnya belum
unit.
bisa pindah ya?
Okay. Yes, it's enough. 3, yeah. 3 is enough. And I will pull the guide wire here, out, and the air. Yeah, you can see the tip of the sheet in the middle of the left ventricle. Then we will use a mesh ball or basket as the introducer help us to across the mitral valve safely. You can see you can see a ball, a basket. Let me, yes, move.
This is the balloon. So before that.
You can see the basket safely advancing to the left atrium, and then I will push the sheet. You can see the sheet tip now just below the mitral and cross the mitral valve to the left atrium. Then we pull out the basket out. Yes. Now 11, right? Okay. The 10 or 11? Yeah, 10, yes. It's a 10 centimeter. The cheese is 10 centimeter deep into the heart. Then you can see, this is the, where is the camera? It's camera. Yes, I can see the camera. Now it's a device. It's a device. You can see that. It's a device, right? Device. Okay. It's not very long, maybe half a meter. Okay. 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 Then also the air.
Dr. Laiwei, how do you know the position of your devices? Is it in A1, A2, or A3 position?
Yes, you can just see the 3D rotate and move to the center. 朝前。这给我前一点。Okay. Now you can see the upper clamp is open, and then we will pull the sheet out, let the lower clamp open. You can see carefully. Yes, open. You can see that? Like
yes,
a two bird,
yes,
2V. Yes. That's 3D. 稍微薄一点，对。Now I believe it's just in the middle of the mitral valve. Yes. Yes, I will turn clockwise 90 degree to make sure that it's you can right this direction. So it's easy to rotate, to rotate and to find the central place. And if we want to move the clip, the clamp to A2, yes, it's A2. You want to P2, the P2. The 1, 0, 1, 3, sorry, 3. And we can rotate. It's very safe and easy for us to find the right place. C1, you want C1, yes, C1. C2, all right, so just cost us seconds, several seconds, we can find the right place. And of course, today's patient, Dr. Dong, you can show us the lesion, the prolapse of P2 near P1, right? So I should put the clamp here and near P, sorry, maybe here, maybe here, right? I need 2D. 2D. Okay, now I'll pull back the lower clamp down to the ventricle. Yes.
Yes, I want to ask, as a cardiologist, sometimes when we doing it in master clips, we use a Doppler, color Doppler to see the central jet. So do you do this approach, or you do the 2D in echo?
Yes,
do you
sure.
need the color Doppler to do that?
Center.
The position.
You can color. You see the jet. Yes, it's the lesion, right? 好，那这放大。See that, and 3D.
I think we are back to the CAT lab now, Dr. Diki, because I just saw the image of Micra. Okay, please, Dr. Yamin. Dr. Sunu, we are back to you now.
Okay, Dr. Yamin.
Can you update what is going on?
Okay, first, I would like to show the camera. Can you show us the position of the groin? Yeah. So I have inserted in the introducer, Dr. Yamin, but as we realized that the size of the introducer is quite big, the outer is 27 frames. So prior to this introducer, I have escalated the sheet to the 16 and 18 frames. So can you show us the fluoro that we have stored? Yeah. So initially 8 frames, and then we changed to the 16 frames. Next fluoro. Yeah.
We are not seeing the fluoroscopy yet, Dr. Suno.
Nggak kelihatan fluoronya?
We are still seeing your littlest pacemaker
Yeah.
zooming. Yeah.
Okay, sorry for that. Anyway, so we are ready to insert the Micra, the littlest pacemaker, through the introducer, Dr. Yamin. And before that, we have to make sure that there is no air bubble along with the delivery sheet, like this one. We can see here, we give a continuous drip of water saline, and then we put the Micra inside the delivery sheet, yeah, and we put into the introducer.
Okay, I think we have 3 panelists here together with us. So I would like to have comments, opinion. I think from the first panelist, Dr. Diki first, and then we'll go further to Dr. Budi Aryo Tejo and Dr. Rina. Please, Dr. Diki, any comments or opinion with regard to this procedure, patient selection or technique?
Yes, thank you, Dr. Yamin. Thank you for having me here. Can you hear my voice? Hello? Can you hear me? Dr. Yamin?
Yes, a bit echoing, but we managed to understand what you are saying.
Okay, great. I have a question and comments to Dr. Sunu. Sunu, can you hear me, Dr. Sunu?
Yes, I can hear, Dr. Diki.
Okay, so we know that this device and the introducer is 27 French, so it is quite big. It is the biggest that we have actually for an EP intervention. So the vein has to accommodate 27 French introducer sheet. So for selecting the vein or the puncture site, how do you find the best puncture site of the femoral vein? What do you look for, or what do you do?
Okay, thank you, Dr. Diki, for the comment on this. Yeah, exactly. This is a pretty big size of the sheet, yeah, 27 French of the outer introducer. So first, we make sure that there is no anomalies of the vascular. So we did the duplex prior to this procedure, and we confirmed that there is no abnormality of the vessel in the groin area, the femoral artery and femoral vein. And then, yeah, we try to advance the wire actually using the stiff wire, but it was in this patient, it was a little bit stuck. So we changed to the yeah, we changed the wire to the soft wire, the thermo wire, but then there is no problem until the right atrium. So that's what we did to the patient to prevent the presence of potential complications.
So what I sometimes do, and most of the times if this patient is a smaller lady, is that I use duplex during puncture, because I want to have the puncture site not below the bifurcation of the femoral vein, but above the bifurcation, but not too high as well. So it was into the inguinal vein. So yeah, that would be my recommendation for maybe in electrophysiologists to do this for the first time. Use the duplex. Afterwards, if you're already confident with the 27 French, maybe you can do it without that. But especially in little ladies, I would really recommend to use duplex. What do you think, Dr. Sunu?
Yeah, I agree. If we, especially as we are not sure about the condition of the normality of the vessel in the groin, then that will be very helpful. And actually we did, but the duplex we did yesterday, so prior to the procedures.
Okay, Dr. Sunu, please proceed with the procedure. We have to switch back to OT because I think a very critical moment is being
Dr. Yamin,
observed.
I would like to insert the micra to the right ventricle. Shall I show live or later on?
Maybe you can have it recorded and then show it to us step by step. I think we could still appreciate and have some very good discussion.
Okay, thank you, Dr. Yamin.
Okay. Thank you. Okay, thank you, Dr. Yamin.
Yeah.
Okay, press Laiwei.
Tolong Mas Yudi, make sure bisa dilihat reference-nya.
I understand you are about to perform the clipping of the mitral valve. please continue and tell us what's your procedure, please.
Yes, yes, I'm waiting here, and we have finished the clamp and close and waiting to release. So totally we to successfully capture the anterior and the posterior A2P2 only cost about 5 minutes, and now we close and the echo physician measures that the length of the capture is enough, and the gradient, mean gradient of the mitral valve is only 3, and we think there is only mild, trace to mild residual regurgitation jet, so we want to release now. Okay, and if you are interested, we can show you the video afterward. Okay, let's wait. Okay, so we want to release. Okay, 加强. Okay, strengthen. Yes, here you can see that. Here, 加强. Release. There's a green button on the device, and turn it. Okay, release. And we will pull the device out. The sheath, yeah, yes, thank you. Yes. Now, okay, very good. Only trace left, and you can see. We plan to put 2 clamps because of the width of the prolapse is very wide, but now we only put 1. I think we can solve the problem, and just the middle of the A2P2 and 2 orifices, very beautiful, and the bridge A2P2 is complete. There is nearly no residual regurgitation, and you can test the gradient now.
Yes.
Gradient, okay.
Yeah.
Okay, thank you, Dr. Lai Wei. Professor Ameliana, you still in the OR?
Sorry.
Prof,
What
could you,
did you ask?
explain a little bit about what happened, what do you see in the OR, just before and just after the clip of the mitral valve?
So maybe I can explain by showing you the TE video here. We have a nice picture. Which one? The before the grasping. Before the grasping. So down. Here. Yeah, here, maybe here. So you see, first we try to position the clips. I don't know, I just call it clips. And then we look at the leaflet. The leaflet has to sit on the clips. So you can see that the AML and PML sit nicely on the arm of the 2 clips. And then after that, if the position is okay, which one the one that we are going to. So you can see this is very nice, sitting nicely, AML and PML on the arm of the clip. And then after that, we just press you see, the surgeon is going to press that with the second clip, with the upper clip, and then the other is the other one. Okay, it's going down. Okay, and then the clip. Oops, you see, it's nicely grabbed. And then we have to measure the first before the procedure. We have to measure the length of the AML and PML to be sure how much tissue are in the clip. So if we have a lot of tissue, we are safe. So this is the length of the AML after the clip is 1.6, but before the procedure, the length is 2.5 2.3, so it's 7 milli. 7 milli is nice. And for PML, before the procedure, the PML is 1.5. And then after the procedure, it's 7 milli. So there is 7 milli tissue in the clip. So it's enough. So it's safe for us. And then we measure the mitral valve gradient. It's only 3. So, you can see the residual mitral regurgitation is very mild, and after deployment, it's even milder, maybe trivial, and I consider that this is a successful procedure. Alhamdulillah.
Alhamdulillah.
Thank you.
Thank you. Okay, thank you very much.
So
Dr.
this is after
Ameliana.
the release. This is after release. You can see the residual is even smaller, trace maybe.
Okay, Dr. Sunu, we are back to you again. But before explaining the further step you have taken in this procedure, I would like to have the opinion of our panels here. So I'm sure that a lot of questions as referring doctors with regard to this procedure. I would like to invite Dr. Budi Aryotejo first. Dr. Budi.
Yeah, thank you, Dr. Yamin. Dr. Sunu, can you hear me?
Yes, Dr. Tejo.
Yeah, thank you. We have seen that you have deployed the MICRA, but before I have some question. For the patient, the indication for the permanent pacemaker is no questionable. I think there's a clear indication for the patient. He experienced the syncope with documentation of sinus pause more than 3 seconds. So there's a class 1 indication for the permanent pacemaker. But as we know that leadless pacemaker is quite sophisticated device for us now.
Sorry, Dr. Tejo. Can I have more louder, please?
Oh yeah, thank you, Dr. Sudu. As we know that the leadless pacemaker is still a sophisticated device for us right now, related to the cost of the device, related to the conventional pacemaker. As you stated in the slide before that this device has lower risk of the complication related to the pocket and the lead. But I would know, is there any special consideration for the patient to take leadless pacemaker, but not the conventional single chamber or dual chamber pacemaker? That's my first question. And the second question is, how can we pick the best site to deploy this device? As we know that we have to deploy in the septal area, but which part, the best part to deploy this device? Thank you.
Thank you, Dr. Tejo, for the comments. Can you hear my voice?
Yes, Dr. Sunu.
Yeah. So the first indication for this leadless pacemaker, of course, if we have the patients who have no proper vascular access for the implantation for the insertion of the lead. For example, patient with the routine hemodialysis, in which he or she need the vascular access to do the hemodialysis, then the presence of this micra or leadless pacemaker will be very helpful for them. Second one is the one who have the atrial fibrillation, so especially the permanent AF, in which we don't need and we cannot do the atrial pacing. Then the presence of this leadless pacemaker is good for the patients. Although we have to notice also, Dr. Tejo and all of the participants, that the leadless pacemaker, currently we have a micra AV, in which we could sense the presence of atrial kick in the ventricle using some method of this micra AV. But currently what we implanted the patient is Micra VVIR. This is from the first comment. And the second, regarding the placement, so can I also show the, I think this is related to the step that we have done, Dr. Yamin.
Okay, please.
Yeah. So, yeah, after we...
sorry,
we show the,
we are not seeing the fluoroscopy image yet.
yeah,
Can you,
please show me, please show the participant the fluoroscopy.
Yeah.
The step by step.
Okay, okay, it's clear now.
Can you see, Dr. Amin?
Yeah. Carry on,
Back
carry
to
on.
the initial, when the introducer still in the IVC. No. Ya, mundur lagi. Mundur lagi. Terus. Ya, ya, that one. That one. No, next. Okay. Yeah, this is the initial, before the introduction of the pacemaker to the right ventricle. So the introducer we put in the proximal part of the IVC, just below the junction with the right atrium. And then we put the delivery sheet to the right atrium and crossing the tricuspid valve, like this one, Dr. Amir. So this, after we cross the tricuspid valve in the RAO positions, then we move to the LAO positions. Next slide. And next fluoro, yeah. Yeah, these LAO positions will give us the clue that the directions of the delivery sheet is toward the septum. If we can see here toward the septum means in the fluoroscopy close to the spine as we look at this. And then we confirm using the contrast, Dr. Tejo. Next slide, next. Yeah, we inject contrast. Yeah, to confirm the location of these, the delivery sheet. And we can hear from the RAO view, the contrast, we still have some kind of gap between the tip of the delivery sheet and the myocardial of the right ventricle. It means this kind of space showing that it is in the septal set, and we confirm using the LAO view, LAO. Yeah, this LAO view again confirm the directions of the delivery sheet to the septum. And this is the ideal location, actually, if we could get the good threshold and good impedance and also good R wave. So, not the inferior wall, because inferior wall is very thin, but also not in the anterior, but in the septum. And please go back to the RAO. Yeah, like this one. This is the, not so apex. So this is, usually in the RAO view, we could define into three parts, the lower, mid, and the higher part of the septum. This one is the lower part of the septum of the right ventricle. This is my, my comment on your question, Dr. Tejo.
Okay, I think we have also a non-EP panelist here. Dr. Rina, maybe you would like to raise some issues with regard to these procedures?
I think regarding, I cannot give any comments regarding how the procedure is done, but I know the concern of doing either leadless pacemaker or just transvenous pacemaker for only ventricle pacing is the desynchrony, right? And how about this patient? We know this patient still have atrial pacing, so this patient is still in sinus rhythm. And we use, this is the ventricle pacing, right? For the leadless pacemaker is the ventricle, only ventricle pacing, right? So I think the resting question is about how about the atrioventricular desynchrony and interventricular desynchrony for a patient like this. Thank you.
Dr. Sunu, this is very EP question, I think. I'm surprised by Dr. Rina's question. It's very EP.
Yeah, Dr. Rina actually wished to join the EP previously. Well, thank you, Dr. Rina, for the comment. Yeah, of course, any VVIR or ventricular pacing pacemaker will have the effect of the desynchrony and also the future of the development of AFib. Yeah, but yeah, if we look at this, the halter of the patients, actually in the number of the sinus arrest or sinus pause is less than 10%. So we expect that we will prevent those 10% potential episode of the syncope that the patient has. But the left ventricle failure or LV dysfunctions due to the VVIR pacemaker, mostly when you have more than 20% of the ventricular pacing. So I believe that even if we put the single chamber pacemaker VVIR in these patients, but considering the main symptom of the patient is syncope, we will prevent that syncope, and we could set the lower rate not so high, like maybe 50 will be enough. Then we will expect that the number of ventricular pacing will be below 10%. That's my comment, Dr. Amin.
Okay, carry on with the rest of the procedures, Dr. Suno. We are anxious to wait the result of this procedures.
Okay, so can I continue the procedure and showing to the audience, Dr. Amin?
Yes, carry on. We are on
Yeah.
still.
So after we deploy the micra, please show the slide of the deployment, the fluoro of the deployment.
Please show the fluoroscopic image.
No, the deployment before this.
Okay.
Before this. Yeah, this is the time when we deploy the micra. So after we confirm the location is the septal part of the ventricle, then we deploy in this way. Okay, next fluoro. Yeah, we use the highest resolution of the fluoro, and we have to confirm whether. So we have a 4 tine in the micra, in the leadless pacemaker.
What is the frame rate, Dr. Suno? What is the frame rate to be able to see the tine movement?
Yeah, we use the 15 frame rate, Dr. Amin.
Okay, great.
And if you notice this, please make it slower, so that we can see the movement of the, slow. So, okay. So we not next. Terus. Yeah, we notice the movement. So there are 4 tines in the micra, and the movement of the tine, we should confirm at least 2 tine is attached to the muscle of the myocardium. Okay, next.
Yeah, I think it's very important point made by Dr. Sunu to avoid the possibility of migration or dislodgement after releasing the device.
Yes, Dr. Amin. So we confirm also in the LAO view. Next slide. Next fluoro. Next. LAO. Yeah. So I would like to ask before I fully deploy the device, I need the opinion of the panelists. How many times you seen that it is already attached in the myocardium? Next.
Okay, Dr. Diki, can you see clearly how many times already attached very well to the septal area?
I cannot see very clearly, but as long as what I see is I can see about 3 times removed during the hugging. Am I right, or do I see it not clear that there are 3 times?
Okay, I think Dr. Diki could not see very clearly. What about Dr. Budi? Can you see the times? Well, a bit.
I think there is 2 clear times.
Okay, at least 2 are attached, Dr. Sunu. So are you confident to release it now, or you still have some maneuver to confirm the stability of this position? Any certain additional maneuvers, Dr. Sunu?
Sorry, Dr. Amin?
Suppose if you see more than 2 times test already, any other additional maneuvers to confirm the stability of the position?
Yeah, we do the tuck test to confirm that it is already attached to the myocardium, Dr. Amin. And we are now measuring the the micra, Dr. Amin.
Yeah, you are conducting the pacing threshold, right?
Yeah. So, please check. So can you, so can you see the measurement?
Yes, of course.
Yes, you can see it.
I think, yeah. What is the threshold like? I think 1.25, is it?
Yeah, the R wave is 10.4, and the threshold, the impedance, jatuh.
Be careful. Is it asystole or just dislodgement of the lead?
No, the programmer head.
Okay.
Jatuh. Okay, so the threshold, please measure.
What is the minimum acceptable threshold for micra? Is it comparable with the conventional transvenous pacemaker?
Okay, for the micra, if we put the threshold of 1 or less than 1 with the pulse rate of 0.24, we expect to have the battery longevity of more than 10 years. But if we have less than 2, we expect to have the battery longevity of about 8 years. So that's for 0.24. But we also can measure using the 0.4 pulse width, Dr. Amin.
All right. Any comment, Dr. Budi Aryo Tejo?
Yeah, I have a question. What if the threshold is not acceptable for the lower 1/3 septal area? How far can we go, how high can we go along the septal to try to deploy this device?
Thank you, Dr. Tejo. So as I gave a comment previously that we have 3 possible locations in the septal of the ventricle, the lower part, the mid, and the higher part. We are now in the lower part of the septum, and now we have a R wave of 10 and then the threshold of 1.13 at 0.4 and 1.25 at 0.24. Yeah, I would like to have the opinion from the chairman and also the panelists if we could accept this property of the micra or not.
I think we are convinced, we are confident for you to release this device. I think all the parameters are acceptable and the position looks good. Carry on.
I would like to give a comment to Dr. Tejo's question.
Yes, Dr.
Okay,
Diki.
please, Dr. Diki.
Frenick?
Yes.
Okay.
Yeah, I would like to give a comment to, sometimes if we see a little bit higher threshold, we can wait about 5 to 10 minutes to test again. So in many cases, the threshold will be improved after waiting 5 to 10 minutes. So don't just move the micra to another place, because every repositioning is also a risk involved. So if you see maybe the threshold is 1.8 or 1.7, just wait 5 to 10 minutes. In many cases, the threshold will improve to 1 or even below 1. So don't directly move the micra if you have a borderline or a little bit higher threshold. So instead of repositioning directly, just wait.
Very good point,
And
Dr. Diki.
Yeah, and for Dr. Sunu's parameters, I think this is acceptable with 1.1 at 0.4 millisecond.
Okay, thank you, Dr. Diki and Dr. Yamin. Since Al-Mukarram and Al-Ustad already agree, so I will release the micra, yeah?
Yeah, Please, yeah, okay. We are seeing now the fluoroscopic image, so we are anxious to see how this device is being released, and then let's see. Okay, Dr. Sunu, please proceed. Don't forget your doa.
Inshallah. Yeah, I think this is one of the dug period during the cutting the wire.
Dr. Sunu, our surgeons are really ready to help you out in case, but we hope it's not going to happen. Don't worry, even though they are very close to us now.
Thank you. So please help me by dua.
Yeah, because it's suggested by our Ustad is here, Dr. Ustad Isman Firdaus. So yeah, I think we need to see your fingers, your hands.
Tell us which one do you cut, Dr. Sunu? Which one of the cutters?
Yeah, I'm still trying to see in the tethers. Wait.
So you are preparing for
Okay. Okay. So I hold these two, but the camera cannot see it.
Yes.
Yeah.
Okay. We can see it now. Yeah.
So I have the right side and the left side, and I check which has the most tight. Resistant, and then I will cut that resistant part, the left one.
I think the camera is really taking from your back hand, so we cannot see clearly the what we call it. Not only the tuck, but also the cutting of the string, right?
Yeah. Yeah.
Yes. Yeah. It's helpful. Yeah. It's clear now, Dr. Sunu.
Yeah.
Okay.
Okay, I cut.
Yes.
Yeah. So I pull the tether.
Oh, so this is the tucking test, right?
Yeah.
Yeah, I think it's quite stable because you can. The seat is approaching the device, but the position is still very stable. I think at this level, we are here very confident. I'm not sure whether the operator is also confident.
Yeah. Usually I ask the resident to sing Indonesia Raya, and by the end of the Indonesia Raya song, then this tether will finish.
I think it depends on the Amal Soleh also.
Yeah, as long as Al-Mukarram is here, then inshallah.
Okay.
Yeah, I still have maybe 1 more kilometer.
Yeah, I think it's very critical. So I think all the audience can see how the operator is very carefully do some maneuver to confirm the stability of the device before deciding to release it to avoid any unnecessary complication. What is the dislodgement rates of the micra, Dr. Sunu? Do you have any idea from the trials?
Yeah, in my understanding, maybe less than 2%, Dr. Yamin.
All right.
Okay.
All right, it's released now?
Yes.
All right, let's wait for a while. Sometimes we cannot clap yet, I'm sure. Wait for 1 minute before clapping our hands, right? Sometimes too optimistic can cause some disaster. Setuju, Dr. Isman? Okay, 30 seconds, 40 seconds, 50. Okay, we can clap now. Congrats, Dr. Sunu.
Thank you. So I pull the delivery to the right atrium, yeah.
Yeah, I think it's still there.
And confirm the other position, LAO.
Good job, Dr. Sunu. Good job.
Thank you, Dr. Diki. Yeah. Okay.
All right.
Okay.
So, what are you doing?
Lateral,
What is your plan for the access closure, Dr. Sunu? Are you going to have the 2 proglides or a figure of 8? Because it's quite big access.
Thank you, Dr. Aaron. Because the size of the introducer is 27 frames, of course we cannot use just by compression. So we plan to use the figure of 8 suture. Okay.
Okay, we are leaving you for a while, Dr. Suno, because I think we are going to have concluding remarks from our OT team. So please, Dr. Diki.
Okay, thank you, Dr. Yamin.
Pak, sudah ya Pak?
Can you move the camera to the OR? Sorry.
More live, more live.
Okay, closing.
Hello, Dr. Ricky.
Hello, yes, Dr. Amin, please.
Yeah, Dr. Amin in. Yeah. The operation has finished a few minutes later before with good result. I think the residual just only 3 to mild. We are closing the skin now. It's about 4 to 5 centimeters at the anterior aspect of the chest. So the valve clamp just only one. We put there one. Yeah. So actually the operation has done with good results. I think that's the end of the live demo today.
Okay.
Ricky.
Okay, thank you, Dr. Amin. I see there's drain insertion. What size of the drain? Is it 20 or 24?
18.
18, oh, very small.
You put
okay.
just only,
so
yeah,
predicted the bleeding will be minimum, isn't it?
Yeah, there's no bleeding at all.
Okay, thank you.
Okay.
This morning, Professor Laiwei said that he's going to perform exactly the same procedure as he did yesterday. But fortunately, we do something a little bit easier, I think. He only put one clamp in this patient. What do you think? What happened? Do you think? Why the procedure seems easier today? Because of the patient?
Yeah. The Professor Wei is concerning about the width of the lesion. It's about more than 15. So he planned to put 2 clips to accommodate that width. But in the OT, when he put just only 1 clip, so the residual is only a little bit. So he decided to do no more, just only 1 clip only.
Okay, thank you, Dr. Amin. Dr. Sugeng, Dr. Doni, and Dr. Rina, any comment? Final word, maybe?
Yeah, I think congratulations for the team for the very successful procedure. So we learned a lot from this procedure, and then hopefully the condition is sustained, and then we can see for the next 1 week maybe the serial echo. Hopefully that still maintain the reducing the MR. That's all. Thank you.
Okay, thank you very much. Okay, Dr. Amin, Dr. Doni, Dr. Rina, Dr. Sugisma. Oh, other speaker. I think we can conclude that this procedure have complete satisfied and with good result. As Dr. Doni said, we hope it can sustain and can be durable considering the patient condition. So I think it's the time for us to finish this session. Thank you very much for all the panelists and all the surgeons. Thank you. Thank you, guys. Thank you.
Ladies and gentlemen, all panelists, moderator, and participants, we will have a lunch break from 12:00 till 13:00 sharp. And for all participants, may ask questions through Q&A in chat box. Have a good lunch and see you at 1 p.m.
This.
Ladies and gentlemen, welcome back to the International Cardiovascular Summit Day 2. And now we will continue on the last session, which is lecture follow, live demo and discussion on zero fluoroscopy ASD closure. The last lecture will be led by Dr. Radityo Prakoso, and he will also be the operator for the live demo, and Dr. Aditya Sembiring will be the co-operator. As for the panelists, here are Dr. Aryo Suryo Konchoro. Just welcome, Doc. And Dr. Olvi Lelia. This live demo will be demonstrated by Dr. Indriwanto Sakijan. And I will read his CV first. Dr. Indriwanto Sakijan is our senior consultant of pediatric cardiology and congenital heart disease. And currently he is the head of quality committee at National Cardiovascular Center Harapan Kita. And also for the panelists joining us, Dr. Isman Firdaus. Please welcome Dr. Indriwanto Sakijan.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Thank you for organizing committee. We have the last session about the congenital or structural heart disease. So this session is the last but not the least. So the decision have first the lecture, and the second we see the live demo with Dr. Radityo. Maybe the first we hear a lecture from the Radityo Prakoso from the Cath Lab Harapan Kita. Maybe Dr. Radit, can you hear me? So before Dr. Adit, we have three panelists. One is Dr. Aryo Kunchoro, and the second Dr. Isman Firdaus, and maybe Dr. Olvi Liliasari. Dr. Olvi. Okay, Dr. Adit, can you hear me?
Yes, Dr. Wanto, can you hear me also?
Okay, clear.
Okay.
Okay. You have 20 to 30 minutes to give us the lecture about the zero fluoroscopy transcatheter ESD closure. Thank you. Please, Dr.
Thank you, Dr. Wanto. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Praise to the Prophet Muhammad sallallahu alaihi wasallam. First of all, I would like to thank to the organizing committee who allow us to share about the zero fluoroscopy transcatheter ASD closure. Slides. Nothing to be disclosed. Slides. So the issue regarding the classical way for the patients, maybe only one thing, but for the cath lab personnel, it is repeated, exposed to an ionizing radiation in the course of their duties. Maybe the physicians and the cath lab crew, it doesn't feel anything, but exposure to the heart team to scatter radiation is a serious environmental risk for all the team. Slides. So this publication showed a low dose radiation can be achieved for transcatheter ASD closure even in a complex ASD. By following the recommendation, reduction frame rate, avoidance the lateral view and sign acquisition, and limitation of fluoroscopic time by avoiding unnecessary maneuvers, and last but not least, using echocardiographic guidance as much as possible. Or could we just do the whole procedures by using the echocardiographic guidance only. Slides. So, echocardiography imaging in transcatheter structure intervention is rising in cases and device developed over this period. And there has been increased focus of developing the role of structural imagers or marshallers amongst the cardiologists. There has been growing initiative to develop the field of interventional echocardiography, especially in Asia. Slides. So you can see on the left hand, there's the old Airbus, there's the Garuda first Airbus, were facing forward crew cockpit. At that time, all of the airline refused to have two cockpits only on the wide body aircraft. And you can see the classical steering wheel is in front of the captain. And the right side is the new generation of the Airbus using the joystick only without the steering wheel. It's scary, maybe, but why walk if we can fly? Slides. So this is our initial zero fluoroscopy experience in Harapan Kita Hospital. In conclusion, the transcatheter closure, the ASD without fluoroscopy, is feasible, safe, effective. However, our experience is still limited, and a longer follow-up is needed in the future. Slides. And more patients are intervened with the zero fluoroscopy guidance in our center, started with the low body weight ASD, PDA, VSD, and other slides. This is our milestone of the zero fluoroscopy technique in Harapan Kita, started at the ASD closure in July 2018, PDA closure, sinus vasovagal closure, VSD closure, bound pulmonary valvuloplasty, PFO closure, and many more. Slides. And Alhamdulillah now is widely accepted also in Indonesia. There can be working also in those kind of techniques in Medan, Padang, Bandung, Malang, Solo, Denpasar, Manado City, and Makassar. Slides. This is our experience in septal defect and ductus arteriosus closure with the zero fluoroscopy guiding in Harapan Kita. With the ASD closure is the most effective, is the successful rate is 97%, followed by the PDA closure, and the last are the VSD. While the VSD is in the lower successful rate because it's challenging, yeah, but it could be done by zero fluoroscopy. Slides. This is our experience in the ASD closure. So the patient is 279 patient with the age mean 26 years old, the weight is mean 43 years old, diameter defect is 20, the procedural time is around 53 with a successful rate is at 97%. Slides. And I want to share to you all how to do this procedure. Slides. First of all, until now we could only use for the secondum ASD. Secondum ASD is the most common congenital heart disease with the most common type, the ASD 75%. And you know from the film, you can see this is a very easy procedures. It's just putting the delivery sheath on the pulmonary vein, and slowly we retract, and we can open the left-sided disc and then follow by the right-sided disc. The transcatheter closure has a comparable efficacy with the surgery. Slides. The TE imaging helped to ensure the defect suitability to device closure. Type only the secondum ASD. The size is the same as the conventional one, 5 to 40 millimeters, number of the defects, single or multiple defects. The RIMS adequacy is the same. No other significant surgical abnormality requiring surgery. Evaluate defect morphology, septal alignment. Is there any prominent estachian falls or IPVD? Slides. The rim evaluation, first, we have to evaluate the SVC and IVC rim using the back of a view. Yeah, the position of the 80 and 100 degrees, and evaluate the posterior mitral and inferior rim as a 0 degree. Slides. Why is defect assessment is very, very important? Because we avoid the erosion and immigration of the device. First of all, pay attention for the large ASD, the multiple rim deficiency, septal malalignment, and hyperdynamic ASD. The crux of successful lies in proper device alignment with the respect of the defect and surrounding the structure. Slides. So the procedures started with the sedation. We have already sedated these patients. Give the heparin 50 to 150 unit per kg. Administers the prophylaxis antibiotics. Right heart catheterization is being done as needed. Not all the procedure need the right heart catheterization first. The evaluation the ASD is mandatory. Choosing the appropriate device size, appropriate delivery sheath, device deployment, and then the evaluation. Slides. So when to do the right heart catheterization is when non-invasive imaging is of sufficiently high quality to estimate the PA pressure. Not every patient with the ASD requires the diagnostic catheterization before the surgery. So, young patients with the pulmonary overcirculation and failure to thrive, the oxygen saturation is more than 95%. Only systemic to pulmonary shunting may undergo closure without the necessarily requiring the right heart catheterization. But the inconclusive non-invasive imaging data, older adults with a moderate to high probability of pulmonary vascular disease and exercise-induced sinuses need right heart catheterization before deciding whether we can close the defect or not. Slides. So device size selection is around 20 to 20% the larger of the diameter defect measured by TE, depend on the shape and size. Slides. So delivery system should be used properly. Also the size. Slides. And this is the TE proposition. This upper esophageal, mid esophageal, and transgastric view. Slides. So first of all, we just puncture with the pain. Yeah. For the second one, please pay attention to the catheter that comes from the IVC. How to put the catheter to the puncture sites is the degree is around 50 to 60 degrees from the 12 o'clock position. And then please slides. No. Before that. Okay. And then once the catheter go inside the IVC, and you can use the position of the mid-esophageal with the short axis view. And you can see here the catheter is across from the right side to the left side through the ASD. Slides. Okay. Once in the catheter inside the left atrium, you can use this position also to put the catheter inside the left upper pulmonary vein. It's much easier to put the catheter inside the left upper pulmonary vein instead of the right upper pulmonary vein. Slides. Okay. Yeah, you can see. Okay, the catheter is inside the pulmonary vein. Slides. Okay. This is the 3D imaging from echo. You can see the catheter is in the left atrium. Okay. And then slides. Okay. After that, we deploy the device. You can see from the center of the image, this left atrial disc has been deployed, and then the right image, you can see you can pull the left atrial disc until to the intra-atrial septum, and then after that you can deploy the right atrial disc. Slides. Once it's deployed, first of all, you have to see the position, yeah, and you may make a tap test or wiggle test to ensure the device is attached to the interatrial septum. If in the fluoroscopy technique, you can see from the apical four-chambered view to align the ASD, you can see also from the short axis view or the long axis view from the TAE. Once it's the position is okay, you can detach the device. Slides. What makes a successful procedures? The quality of peri-procedural echocardiographic guidance is a must. So if the peri-procedural echo is not clear, or the marshaller cannot demonstrate or cannot perform giving you the good image, do not start to do the zero procedure. The correct assessment of the defect with its marginal structure, the experienced interventionist, also the marshaller, understanding of the device behavior and the evaluation of the device relationship to neighboring intracardiac structure. Slides. How about the pregnant ASD? Slides. Indication of the ASD closure intervention in pregnancy, with the hemodynamic compromise, with the functional class heart failure more than 2, with the recurrent stroke prior to or during pregnancy. Slides. When to do the percutaneous intervention. If the intervention is absolutely necessary, the best time is after the 4th month in the 2nd trimester. By the time organogenesis is complete, the fetal thyroid is still inactive and the uterine volume is still small. So there's a greater distance between fetus and chest in the later months. Slides. Yeah. Previously we do with the classical fluoroscopy technique. Slides. This is our case in Harapan Kita. Slides. Yeah, at the time the patient is in a pulmonary hypertension also. After giving the anti-failure drug with the intravenous strips of furosemide, the clinical condition is still the same, but the patient experience of the oligohydramnion. So the OBGYN team asked me not to do the intravenous strip furosemide, and we plan to send the patient to the cath lab to do the SD closure percutaneously. At the time, our marshal asked me why to do without the fluoroscopy technique. So at the time, I just answered, "Can we do it?" And then, yeah, if we do not, we did not do at that time, we can maybe until now there's no zero fluoroscopy intervention in structural or congenital heart disease. So at that time we do first the right heart catheterization with the zero fluoroscopy technique also, and the results is eligible to close, and then we close the defect. Alhamdulillah, it can be closed, and the patient improving in condition and have good delivery history also, and now she's safe also with their babies. Slides. This is the classical AC closure. It's very easy. We did a lot of zero fluoroscopy technique AC closure, and we tend not to use the fluoroscopy technique in ASD closure sites. And how about for the TTE only procedures? It can be done also, especially in the child less than 10 kgs. Why we did without TE? Because we don't have that kind of TE in our cath lab. It's possible and also successful sites. How about the large and malign ASD? Can we close also with the zero fluoroscopy technique? Yes, absolutely. So we use the balloon assisted technique. The technique also almost the same with the classical fluoroscopy technique. We use the sizing balloon. What is the purpose of having sizing balloon for the balloon assisted technique? The purpose of the balloon assisted technique is to make the whole of the ASD smaller, so we can place the left atrial disc on the left atrium and also the right atrial disc in the right atrium easily. Slides. This is zero fluoroscopy first moment. Maybe, are you there? Or are you the next? Slides. So, interventionists should rely on echocardiographic guidance whenever possible to limit unnecessary angiographic, to keep the radiation dose as low as possible for this radiation-sensitive population. A complete understanding of zero fluoroscopy top procedures is very essential for successful outcome, both for the interventionists and also for the marshal. Slides. Thank you very much.
Thank you, Dr. Edith. A very clear presentation and very nice, because now issue for the reduced radiation is all the place that issue for the reduced radiation. Before we proceed to the live demo, maybe can I ask Dr. Alfie about the Dr. Adit presentation? Can you, do you have comment?
Thank you, Dr. Indriwanto. Yes, Dr. Adit already gave good presentations, and this is our experience in Indonesia, especially in Harapan Kita, that we did the first zero fluoroscopy a few years ago, and this year when I was overseas, they also support. So pediatric cardiologists and also cardiologists overseas is increasing their ability to do the zero fluoroscopy, because the advantages of the zero fluoroscopy is lesser radiations, and we don't have to use heavy leaded gown. So this is emerging topic in United States and other countries, because they try to do a lot of cases with zero fluoroscopy, especially for the structural heart disease. So I think it's a very good improvement for our institutions. Thank you.
Thank you, Dr. Alfie. Maybe Dr. Isman, do you have comment for that?
Okay, thank you, Dr. Indriwanto, and congratulations, Dr. Adityo, my friend, for your outstanding achievement in the zero fluoroscopy in the country. So, but in every procedure, especially the new technique, is very important, effective, safe, and efficient for every kind of patients. If you say this procedure zero fluoroscopy, why you still need the procedure in the cath lab? The procedure should be not in the cath lab if zero fluoroscopy. I think better in the next features, for every procedure for ISD closure, no need cath lab anymore. go to the, we can change to the non-cath lab room, like the other OT. And the second one is, what the frequency, the switching rate for your experience, more than 100 patients with zero, switching rates from zero, no need fluoro, and you change strategy to fluoroscopy. Is there any data there?
Thank you, Dr. Isman, my friend. So at the nowadays in Harapan Kita, the equipment is still in the cath lab, so I cannot move to the outpatient clinic or to my room in the 6th floor of the ventricle building. And the second one, what's the convert rate in ASD? 0%. Yeah, we never convert to the fluoroscopy for ASD. So you know, the 70%, the 3% is due to the Marshall cannot give a good image for the defect. Yeah, so I think here we appreciate it to our Marshall to overcome those problems, also to display the image much better, to convince us to do the intervention.
Thank you, Dr. Radit. So before we proceed to the live demo, maybe Dr. Aryo, can you do you have comment about the non-invasive main view?
Oh yeah, thank you. So, greetings, Dr. Radit, also my friend. So, hello, how are you doing, Dr. Radit? So, I think from my point of view, I think I'm an echocardiologist, so doing the echo. So, yes, as Dr. Radit mentioned, that zero fluoroscopy requires very expert echocardiologist. The one who's doing the echo is going to be the guide for all the process of procedures. So it is very important that, I think the first rule is to make sure that the person doing it is available. And the second, I think the images quality is good. And no matter how expert you are, if the images quality is not there, so I don't think zero fluoroscopy is a choice. And the third, I think there's a understanding between operators and also echocardiologists. I think that's also the most important part of these procedures. Whenever you don't trust the echo or the other way around, so we might compromise the procedures or the successful rate of the procedures. So, and also the other thing is, for my opinion, I think we have to be honest whenever the quality images is not there and we find difficulties in the giving or showing you the images which you required. And then we have to be honest that we have to switch to the fluoroscopy. So in this point of time, I think it's the fluoroscopy, and we have to prepare for the unprecedented event, which we don't want, but might happen. So I think fluoroscopy cath lab has to be ready when we have to switch to using fluoroscopy. I think that's from my point of view, Dr. Indirvanto. Thank you.
Thank you. So, Dr. Radit, it's not my friend only, this is my boss.
No,
okay,
you are my teacher, Dr. Wanto.
Maybe from the audience, or from audience here, or from the online audience, if you have a question, maybe there's in question and answer, have the one. This ada Q&A. Dari sesi yang sebelumnya. Okay, now we try to proceed to the live demo. Before the live demo, maybe Dr. Radit can introduce your team and what kind of the patient, please.
Okay, Dr. Adit will introduce the case. I will introduce the team. First, this is our my cooperator, Dr. Aditya Agita Sembiring. Yeah, please, Dr. Adit.
Hi, Adit.
Yeah, okay. And Dr. Rina, she's the marshal.
This is the famous marshal.
Asas naikin dulu. Naikin. Iya. Iya, angkat sedikit. Yeah. Okay, the camera.
Sorry, Dr. Rina. Dr. Rina. Hi,
Where's Dr. Rina?
I can see Dr. Rina.
Yeah,
Thank
okay.
you. Hi.
Oh, there.
Okay.
There. Okay, and this is Mas Agus, the scrub nurse, Mas Agus, the circulate, Nur, anesthesiologist, Dr. Kadek, where's the Dr. Kadek? Outside.
Okay.
The assistants, Mbak Yuni. Okay, and technician, Mr. Aji and Eka Kokom. Yeah, so that's all of my team with our resident fellows. Okay, please, Dr. Adit, introduce the case.
Okay, please. I can hear your voice. No, still. No, clearly.
Not clear.
Not clear. Okay. Okay, please, Dr. Adit.
So this is okay, next slide. 25-year-old girl with Ics-Hk and motivation with history of recurrent action. Next. During physical examination, the vital sign was in formation. And when we have the white spirit on F2 and increased E2 component, no more program. Next. The chest X-ray showed the enlarged heart with increased pulmonary irrigation. Next. Last examination are within normal limits. Next. ECG showed normal current frequency with right axis deviation and right ventricular hypertrophy. Next. The echocardiography, both from transthoracal and transesophageal findings, we showed that there is a gap in interatrial septum with diameter of 16 times 12 millimeter, still left to right shunt, with good aortic rim, good posterior rim, IVC, SVC, and AV rim, or atrioventricular rim. Next. This is good LV function from transthoracal echo, and the ASD is shown in the right side. Next. From transesophageal echo, we can see clearly the ASD, both the mitral and posterior rim, the aortic rim, and the bicaval view is, the rims are good. Next slide. And this is the 3D. It showed a rounded ASD with good rims. Next slide. Still left to right shunt. So this is the diagnosis with secondum type ASD, left to right shunt with a diameter of 16 times 12 millimeter and suitable for device closure. With low probability of PA, pulmonary hypertension, with our plan right now is to do a zero fluoroscopy transcatheter ASD device closure. That is all, Dr. Indriwanto.
Thank you,
Back
Adit.
to Dr.
So, 25 years old lady. So, what you plan, Radit? What kind of the sheet? What kind of the device? And
yeah,
how
thank you.
do you measure the like oval for ESD, there is 60 to 20, 60 to 12 millimeter. So what kind your size of the device? Thank you.
Yeah, thank you, Dr. Wanto. Maybe before we discuss it, I will ask Dr. Rina to explain the real condition of the ASD now. Please, Dr. Rina.
Okay, thank you. Can you hear my voice?
Yes, yes, clearly.
Yes. Okay. Greeting everyone. So this is the echo image of the patient. Can you see?
Your echo is not.
Where's the echo image, please? Can it display to the? Okay, no problem. Just a minute.
Okay,
Okay.
Okay.
Lepas lagi.
Does everyone in the auditorium see the echo?
Yes, yes, we can see.
So as we see in this echo that the patient has adequate rim. This is the posterior and apepal rim.
Hemodynamic data nggak usah.
Despite the adequate rim, some of the posterior rim is quite floppy. And then we can see from this view that this patient also has aortic valve rim. But again, some of the posterior rim is quite floppy. And then this has also happened in the bicaval view. Both IPC and SPC rims are adequate, but partially the IPC rim is floppy. So we try to measure this is the 3D image of the ASD and try to measure the size of the ASD using 3D data, and we get the estimation of 1.4 times 1.8 centimeter with partially floppy posterior and IPC rim. Other valves are normal, and we don't find any other abnormality. Maybe that's what I can explain, Dr. Rina.
Okay, so the size was the final size, Dr. Rina?
14 times 17.
Because of the 14 times
17.
17, and then some of the floppy rims, Dr. Wanto. So I will put the device, the ASD device, by the number of 22.
22. Maybe can you explain to us? Can you measure or?
Yeah, you know how to measure the device selection is about the 20 to 25% of the maximal diameter. So it's times 14 times 17. It's slightly oval shaped with the floppy rim. So we tend to put the 25%, means to 21 millimeters. There's no 21 millimeters, so we put the 22 millimeters. That's all, Dr. Wanto.
Okay, maybe Dr. Alfie, can you comment about the size or the device or something?
Okay, thank you, Doc. If the ASD is oval, how do we choose the size of the device? Because whether we choose the smaller size or the bigger size?
Yeah, since this patient have a floppy rim, so I tend to put the maximal diameters. So, but as the rims is firm, so we can reduce the size, but not less than 20%.
Also, it depends on the rims itself, whether it's floppy or it's rigid.
Yeah, you can see this is the rim is floppy, yeah?
Yeah, yeah.
Okay.
Okay, thank you, Dr. Alfie. One more question about the Marshall, Dr. Rina. What kind of, what the position for the good to see the ESD or before the attempt the device and during the attempt the device?
Okay, usually because we are guiding it using zero fluoroscopy technique, so at first we are going to give the bicaval view because the catheter is coming from the IPC, and then we are going to guide the catheter to go to the ASD, and then going through the left atrium and then the pulmonary vein. Usually the view for doing that is by using short axis view, where we can see both the gap and the left atrial appendage and the left pulmonary vein. And then we usually switching between those two images, the bicaval view and then the short axis view to do the maneuver and do the guiding.
Okay, thank you. Maybe Dr. Aryo, can you comment or opinion about how difficult to be the marshal for ESD closure zero fluoroscopy?
Okay, thank you, Dr. Indriwanto. Hello, Dr. Rina. She's also a friend. So, yeah, I think Dr. Rina has mentioned that also that that how important the images quality is, and I think from this case, I think yeah, it could be the ESD looks apa ya? Looks good enough for the device, but I think another concern from my side, I think that's the floppy side of the inferior and some of posterior side, yeah, Dr. Rina. I think it's on the 90-something angle. We see that some part is a bit thin and also it's a bit, I'm not saying a bit short. For example, it's this case, this view. You see that there's a bit floppy right there. Yeah, so I think, so for a device size selection, so we have to also consider that if it's too big, then it might perforate some part of the rim and then it would dislodge after deployment. That's the thing. But however, in this case, I think the good thing is that it has aortic rim. So I think that's a big advantage in this. And it is going to be very helpful, Dr. Indriwanto, I think. In this case, so we can imagine that the device will hang on at that aortic rim rather than only rely on inferior and posterior rim after deployment. So I think from my side.
Okay, thank you, Dr. Aryo. Okay, Dr. Adit, can you proceed the ESD closure? And so please inform us about the sheet. How big the sheet?
Okay, first of all, we do the vein puncture, femoral vein puncture. We put the 6-French sheath, and then we put the MP catheter, number what?
6-French.
6-French MP catheter. And once we put inside the femoral vein, so Dr. Rina will show the bicaval view, and then we check first, is it true, is inside the IVC? There's the bubble inside there. Okay, so the catheter just inside, and we carefully goes, pull, so you can see the catheter is on the right atrium. You can see, Dr. Wanto?
Yes, yes, I see.
Okay. So it's very easy for the beginners to just push the catheter inside, and if there is some trouble whether the catheter is stuck, so you can use the 0.035 soft hydrophilic wire to make it straight, and it goes easily into the right atrium. So it's very easy. Okay? Okay, and the second one, you can see my hand first, my hand in the puncture side, and the second of my hand is on the tip of the catheter. So you can easily navigate, yeah? Okay, please, Dr. Rina, show the ASD.
Okay, please, this way.
Okay. Okay, where's the catheter? Once the catheter.
The catheter is still in the right atrium.
Okay.
Get to the intraocular septum.
So where's the catheter? Can't see. Oh.
In the IPC.
The catheter has. Okay.
That's your catheter.
Okay, that's the catheter. You can see it's on the.
That way. I think you need to go to the SPC first. Okay, you're going to the.
Okay. 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 Please give me the soft hydrophilic wire. Is it on the SPC or not?
No, I think you pull it back to the IPC again. It's on the IPC. I cannot see it on the right atrium.
Where is it?
Not there. See, you're still
To
on
the
the
IVC.
Still in the IVC?
Yes.
I think in
Okay.
SPC
catheter,
there.
you already directed
Yeah.
to the intraarterial septum, and that's good.
That's the NSVC, and then I will pull a little bit.
Okay. Okay.
Muter.
Let's move again. Move again. Okay, you're crossing.
Is it crossed?
Yes.
It's already crossed?
Cross, but the pointed of
Still
the
in the
catheter is
IVC.
not.
No.
Oh, still. It's pointing downward to the right atrial
Okay.
appendage.
I will turn it around.
Okay.
It's crossed?
No, not yet.
Not yet?
Not yet.
Where is he?
Yes, your catheter is still there.
Mm-hmm.
Still going. Catheter is not pointing to the IPC.
Where's the... No?
Still in the IVC.
Yeah. No, it's fine, it's fine. Where is it?
I think it's already crossing.
Yes,
the
in
left
the
atrium.
left atrium. It's already crossed, Dr. Wanto?
Yeah, I see the bubble not bubble.
You can see
Yes,
the
bubble in
catheter
the
already
left
crossing.
atrium.
Mm-hmm.
Okay.
You can see the catheter inside there?
So can I ask Dr. Adit, how about your confirmation about the catheters at the left atrium or right atrium?
You can see there that the catheter the shadow is inside the left atrium.
Okay.
Please, Dr.
Do
Rina.
you see the pressure or the saturation or not?
Here.
No, yeah. We just see the catheter. If you do not, you still not convinced, you can check with the saturation.
That's
Okay,
the tip.
thank you.
The tip of your catheter is still on the right atrium, and you need to direct it to the PP.
Okay.
So the catheter go to the pulmonary vein, this right?
Yes.
Yes.
I don't think.
It's inside? Not
Yes, it's inside.
inside.
Yes.
Okay. I push.
Yes. See, you see the bubble coming from the left upper PP.
Okay. It's inside or not?
Yes.
Okay.
Here.
Dr. Wanto,
Yes.
can you see?
Yes, we see.
The catheter inside the
pulmonary vein.
pulmonary vein. Okay. So we change the catheter with the delivery sheet. Please prepare the delivery sheet, Dr. Adit. And then, Gus, can you give the anesthesis?
Kenapa, Bang?
Give more. So as an experienced patient, I still remember it's very painful
We clear
to have the
see the catheter
puncture.
at the pulmonary
So
vein.
we have to give a proper anesthetic.
So what kind of device do you use?
Okay, I use the 22 millimeter Sera device from LifeTech to put inside. And we use the 12 French delivery system. And how to change the catheter with the delivery system is by using the 0.035 stiff wire. Please, Dr. Reza. How to, okay, 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 no. Okay.
Okay, delivery sheet is ready.
Okay. Anestesi, Gus. So Dr. Adit has have to prepare the delivery sheet. Indeed.
Maybe before Dr. Adit put the device, if any question, please, from the audience or audience on site and offline.
Offside is in the football match,
Yes,
Dr. Wanto.
now it's 17H World Cup. Okay.
Yeah. Where's the stiff wire, Agus? Okay, first of all, when you have some maneuver, you have to ask the marshaller to guide the procedures. First, I put the stiff wire carefully.
So
And it's very important for the assistants is to make sure the catheter and also the wire in the straight position. And please, Dr. Adit, help me. And then once the cable or the wire is have some resistance. So just carefully pull, just carefully push, and then see whether the position of the catheter is changed or not. Dr. Ina?
The catheter, we can still see clearly that the catheter is still in the pulmonary vein. So usually when the wire comes in, we can see a shadowing move. There is a shadow. Yeah, we can see that.
Okay, Dr.
That's
Wanto?
our wire.
Yeah. Can you see the
We
wire
see the
inside
shadow.
the pulmonary
There is
vein?
the shadow of wire or catheter.
Yeah.
Yeah.
Okay, and by that time also the wire is stuck. Yeah, so cannot move again. So carefully, for the beginners, yeah, who watch this program, you can see you have to make it straight. Yeah, do it straight and carefully pull the catheter in the straight position and ask the scrub nurse also use the straight position. Okay, Dr. Adit?
Yes.
It's already
okay. It's
okay.
already outside.
Okay, and then I need the dry. This is the dry, and also I pull the sheath. Okay, put it here, and ask Dr. Ina whether the wire is still there.
Yes, we can see from
Yeah,
the image
so
that
is
the wire is
in the
still,
good position.
yes, in the good and
So,
stable position and technique.
okay, and then Dr. Adit, please help me to put the delivery sheath. Yeah. Okay. Bismillahirrahmanirrahim. Okay. Okay. And then straight, please. Straight, please. And the position is still there. And I made some incision.
Nice.
Oh. Okay. So, can easily push and make it straight. Make it straight, yeah, carefully. And Dr. Rina is still there? Where's the, yeah.
See, you can
Okay.
see that the wire is still there.
Okay. Still there? Still there? Still there? Okay. So you can see
Dr.
the delivery sheath is inside the pulmonary vein. Is it?
Yes, because we can
Yeah.
see the image change from the just hyperechoic shadow becoming like a double, like a straw appearance.
Yeah, okay. So once it's still inside, so carefully push the delivery sheath, and then we can pull out the introducer. Is it, Dr. Ina?
Yes. Still
Yeah,
there.
still there? Okay, good.
There.
Okay,
Okay.
now it's safe, and please pay attention to decompress or make a flushing, make a flush. So you have to make sure that there's no bubble inside the delivery sheet. I have to pull,
Yes.
to pull.
It's okay to pull. I think it's quite deep in the PP.
Okay, just a minute. Careful, Dr. Adit. Sit. Ketarik? Okay, I was in the, no problem, fine. Is it in the left atrial?
It's still in the left atrium in front
Yeah,
of
yeah.
the appendix. I think.
Okay, you can see the blood. Make sure there is no bubble. Why? Because if there's a bubble, you can make the STEMI or parenchymal angina. Okay, so you can see the delivery sheath.
The delivery sheet is on the opening of the atrial appendage right now.
I will reposition
Try
it.
to reposition it to the PP.
Okay, but
Okay.
okay,
Yes. Let's go.
go inside.
Yes. And you're back to the pulmonary vein.
Okay.
So,
Okay, Dr. Wanto, can you hear? Can you?
Yes. Dr. Adit, can I ask you? Sorry, Dr. Rina, can you see the tip of the delivery sheet is at the orificium, the pulmonary vein, or the left atrial appendix? There is.
Yeah, as we can see earlier, that the PP is being retracted slightly to the
device. Okay.
Okay. Please zoom.
Yes, dibuka. So there's 22 SERA device. So, okay, the audience, can you see the device, yeah? So Dr. Adit will put into the delivery system.
So the SERA is still use the apa?
The EKG?
Still use the screw, Dr. Adit.
Yeah. The ECG shows slight ST elevation, but no problem. Can you give another heparin, please? Huh? Yeah. Another 2,000. Another 2,000, please, heparin.
In
Oxygen,
Zoom,
can you give the 100%
we see the
oxygen, please?
QNA.
Yeah.
Q&A di Zoom.
Zoom, please.
Okay, device ready?
No, just a minute.
Liatin dong, liatin.
Another 2,000 heparin, and also the oxygen.
Can you still, sorry, do you still give the antibiotic before the procedure?
Yes, yes, doctor. So before the procedure, we give the cefuroxime, 1.5 gram intravenous 30 minutes before the procedures. Yeah, the oxygen is. Okay, some problems are, can you see the EKG, the ECG? Can you see, Dr. Wanto?
Not yet, please.
Oh,
Okay,
the
okay.
ECG showed the slight ST elevation. So, but it already goes into the baseline, so it's resolved. As I mentioned before, for ASD closure, please pay attention when you flush the delivery sheath. Because of the large delivery sheath, it must contain the micro bubbles, so it can be make some emboli, such as the coronary emboli. So once it happens, do not panic and give another heparin, and also give the 100% oxygen. Okay, that's the tips.
Okay, device ready?
Okay, now the device ready, so we plan to put the device, okay? Okay, once the device ready, and then you can see, please give the flash, okay. Once it's, yeah, and then we can push the device inside. Okay, so we'll ask Dr. Ina to guide us to put the device.
Okay, when the device is coming, we can see there is an image coming from the straw. We can see that.
Okay, Dr. Wanto.
So the
can you see
device is end of the catheter, end of the delivery.
And we can see that Dr. Radit is already deploy one of the left atrial disc.
But it's still the vein.
Yes.
Dr. Ina, can you see? Can you
short axis
give the image of the interatrial septum?
I will move the image to the short axis view.
And you can see the interatrial septum is on the left side. So I push so I pull the whole system. Where is it? Where is it?
Yes, it's still there.
Still in the left atrium.
Yeah, okay.
Just a minute. Oh.
Because we use a big device, so.
I want to put in the pulmonary vein first.
Okay, back. Okay.
Okay.
You are back at the pulmonary vein. Okay. Careful, you already deploying both of the.
Deploy the RADs.
I think both of the discs is already.
Just a minute. Dr. Rina, where is it? Is it on the?
So here. Okay, just pull a little bit, and then.
Yes.
Yes.
Okay, very good.
Okay.
Okay.
Okay, Dr. Wanto?
Yeah, we see.
Yeah. It's quite difficult to say step by step, but it's there.
Okay, we can see both of the device, both of the disc is already open, and the left side of the disc is at the left atrium, and the right side of the disc is at the right atrium, and we can see we can see from this view that both rims are inserted within the disc, and I will move my image to bicuspal view. We can see here that the SVC rim is already inside, and then the IVC rim is already inside between the disc also. And then I will make sure that all the view is there and all the rims are inserted between the discs.
Okay, Radit.
So,
Yes.
Sorry, do you use the wiggle again?
Yes. I will
Still
do the
use?
wiggle test as mentioned by the marshaller. Like a captain want to park his aircraft.
okay, I think we can do the tuck test now.
Yes. The wiggle start on the what position, Dr. Rina?
We start on the short axis view, so
Okay.
we can evaluate the aortic rim and the posterior rim, whether it's stable enough.
Okay, that's fine.
Okay, it's fine. And then I will do again the tuck test on the bicuffle view. Make sure the IPC SPC rim is already stable too.
Okay.
Okay.
Okay, good.
That's quite a tuck test. Okay, I think from my point of view, it's already good, in good position. What do you
Okay.
think, Dr. Radit?
Okay. How about Dr. Wanto?
Yes.
Dr. Aryok, Dr. Ovi, Dr. Isman?
How about Dr. Aryo?
Okay, the mitral is fine, Dr. Rina?
The mitral is good.
Okay. Yeah, that's the last piece of this all images that you need to make sure that no adjacent structures is being obstructed with by the device. So I think it's good enough. I think, for my opinion, I think it's good to deploy.
Okay, Dr. Alfi. Wait a minute. Okay, Dr. Alfi.
I think it's good. I think it's good, Dr. Adit and Dr. Rina. It's already, you can deploy, I think.
Okay.
Okay, you can.
Dr. Isman?
Oh, Dr. Isman.
Okay, Dr. Adityo, congratulations.
You
It
you
looks
have
nice
done
and
with
it looks
me
nice
about-
and perfected of your device in putting in the SD. So I think it's very impressive.
Okay, okay.
But,
okay,
but
okay. I will detach this, yeah?
Okay, you can detach.
Okay, please. Yo, dit.
Bismillah.
Bismillahirrahmanirrahim.
Bismillahirrahmanirrahim.
You can see the cable there, still attached to the disc, and then we wait until the cable, yes.
Okay.
Okay, we can see that.
So
Cable
how,
is already-
how do you know that the cable is already detached?
The position is slightly changed, Dr. Wanto.
Okay.
You can see the position is now is like a burger sign.
The burger. Thank you.
Okay, this
Big
is
applause for
final
the Dr. Adit
position.
and team.
Okay.
Congratulations. So
Thank you, Dr. Wanto.
for this case, we have two questions. Please open the question. Dr. Adit, do you have the question?
Yes, yes. What
Uh,
the question?
Okay. The first question, how is the progress of the procedural time of the zero fluoroscopy technique? Knowing that this is probably one of the fallback that prevent that the technique to be conducted in other center in Indonesia, beside
Yeah.
the skill, experience of the operator and marshaller. Thank you.
Yeah, it depends on the case, yeah. Mostly nowadays of course, first time is more than 1 hour. Now the fastest way is 10 minutes or 15 minutes, and on average is 30 minutes. So I think all of my friends all over Indonesia have an experience to have less than 30 minutes procedures. But why the data in Harapan Kita is still around 50 minutes? Because the fellow are studying
Training.
on this kind of procedure. So I just we are quite rubbering for the time. So actually, it can be done in the faster way.
Okay, thank you. one question. Next question, please. So, Alicia Putri. Hi, Alicia Putri. Hello, doctor. What a wonderful case. I have two questions. First, to Dr. Adit, how to maneuver the delivery sheet back into the left upper pulmonary vein. And the second, why we choose the device number since the defect is light over. Thank you. Please, Dr.
Yeah,
Adit.
Dr. Lisa. Greetings from Rujak Cengor, yeah. So, Dr. Lisa, once the delivery sheath is falling into the left atrial appendage, so please do gentle maneuver by rotating counterclockwise. Yeah, by rotating counterclockwise, it easily goes inside to the left upper pulmonary vein. And the second one, the device selection. First of all, this device is slightly oval shaped with a 14 times 17 with the floppy rims. So Dr. Rina, me, and also Dr. Adit decided to put the 22 device.
Okay, thank you. So, I hope Dr. Alicia and Dr. Farhan satisfied about the Radit answer. Thank you for the Radit team, Radit, Aditya, Dr. Rina, Pak Agus, and Dr. Kadek, and so all team in Cath Lab. Congratulations about the patient. So we conclude that zero fluoroscopy is important technique because no issue about the reduced radiation at the Cath Lab. Thank you very much, Dr. Radit and team. Once again, congratulations. Thank you, ladies and gentlemen. We have finished the session about the zero fluoroscopy for the ASD closure at what kind is this? ICS Harapan Kita today. Thank you very much, and thank you for the Dr. Olvi, Dr. Aryo, and Dr. Isman for the panelists. Thank you. Saya akhiri dengan wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Indriwanto, and congratulations, Dr. Adityo, for your impressive performance in live demonstration for zero fluoroscopy. And also, I would like to thanks to all the panelists here, all the speakers, all the operators, co-operators, all the supporting staff here, and all the organizing committee, all the technicians, all of my college, the nurse, the scrubs, the technicians, supporting this impressive conference for the first International Cardiovascular Summit Harapan Kita Live. So now, as the chairman of the conference, it is the end of our sessions. So from the bottom of my heart, I'm to say thanks and appreciate for your contribution and for your attendance, presence, and support this first experience for Harapan Kita Hospital organize this tremendous conference. So again, thank you for your coming, and see you next year in the second International Cardiovascular Summit Live Harapan Kita in 2024. Sayonara. Assalamualaikum warahmatullahi wabarakatuh.
And for all the participants, we would like to say thank you. And after that, please make your attendance in the link or in the link chat box to get all the certificates. Yeah. Okay, thank you.
You know I want you. It's not a secret I try to hide. I know you want me, so don't keep saying I've had a time. You claim it's not in the cards and always pulling your face. This time you always keep from me, but you're here in my heart, and who can stop me if I decide that you're my